Royal Commission is now in session.
I would like to begin by acknowledging the Ngunnawal people, together with the Gadigal people of the Eora Nation, the traditional custodians of the land on which Commissioner Briggs and I respectively sit. As we pay our respects to their elders past, present and emerging. Before we begin the hearings, or rather today we begin the hearings into some aspects of the impact of COVID-19 on aged care. The focus of these inquiries will be outlined by Council in a moment, but it is important to say something about the context in which the hearing is being conducted. The timing and the scope of the hearing on this topic are not ideal. The circumstances in which this hearing is conducted from today is very different from those on 14 May, when we announced that we would inquire into certain issues arising from the responses to the pandemic. We find ourselves today in extraordinarily difficult times for the nation as a whole, and for those within or affected by aged care in particular. We had planned to schedule this hearing as late as possible within the time frame available to us for completion of our report in February. However, the impact for the country so far and for many in aged care has been tragic in ways that were unimagined a few months ago, and the full impact is not yet known. We extend our sympathy to everyone who has lost a loved relative or friend to COVID-19. We extend our sympathy and understanding also to those who have not been able to spend time with their relatives or friends in aged care because of the restrictions introduced to deal with the pandemic. We feel your losses and your absences deeply. We have heard many of your stories and have been moved by them. There are many questions which have been raised, which we will not be able to answer within the time frame and resources we have available to us. But we do thank all of those who have come forward to help the nation understand something of the extent of the impact and the appropriateness of the responses in the context of aged care. We need also to acknowledge the willingness of many who have supported and deepened our understanding in this inquiry. It has not been easy for elderly Australians, their family members, aged care providers, staff, external advisors and government officials to respond to our need for information at the same time as dealing with the reality of the pandemic on the ground. And we thank all of you for your assistance. Mr. Rosen.
Good morning, Commissioners. I appear with Mr. Paul Bolster to assist. I too would like to acknowledge the Gadigal people of the Eora Nation, the traditional custodians of this land, and pay my respects to the elders past, present and emerging. Commissioners, COVID-19 is the greatest challenge the Australian aged care sector has ever faced. We all watched with horror the stories of large-scale death in what are called long-term care homes in the Northern Hemisphere in February and March of this year. The Australian aged care sector and the government agencies that fund and regulate it were on notice about the particular vulnerability of the elderly residents in our own care homes. More recently, we've seen the unfolding disaster in more than 100 of Victoria's nursing homes. According to the daily data released by the Australian Government Department of Health, between 8 July and yesterday, over 1,000 residents have been diagnosed with COVID-19. Of these people, 168 have died. Grandparents, parents, siblings and friends, a human tragedy. Presently, 68% of all COVID-19 deaths in Australia relate to people in residential aged care. The evidence that you will hear is that this makes Australia the country with one of the highest rates in the world of residential aged care deaths as a proportion of total deaths from COVID-19. As much as we've been distressed by these stories of human suffering, we have been impressed by the stories of the care workers who have worked in unimaginable conditions to provide these residents with the care they need. These workers display commitment, courage, dedication, and most of all, love. As a community, we owe them a great deal. We should honour the work that they do, but not just by praising them. Talk is cheap. They deserve to be properly rewarded, properly equipped, properly trained, and properly led. And most of all, they need to work in an aged care system that supports their work. Commissioners, on 20 March this year, you decided to suspend our hearing program in light of the emerging COVID-19 crisis. On 31 March, the Prime Minister wrote to you. In part, he asked that in engaging with government and private entities and in exercising any compulsory powers, that you take into account that they are the front line of the fight against COVID-19. In light of the COVID-19 crisis and these matters, on 20th of April 2020, you wrote to the Prime Minister seeking an extension of time in which to complete your report. A reason for that request was the desire to include in your inquiry some consideration of the impact of COVID-19 on the aged care sector. On 14 May, you announced an inquiry into certain issues arising from the responses of the sector and the government to COVID-19, with a focus on lessons learned from the COVID-19 response. As part of that inquiry, you met with the Aged Care Quality and Safety Commissioner and representatives of the Commonwealth Department of Health on the 17th of June 2020. As Commissioner Pagoni explained in a statement made on 30 July 2020, this Royal Commission does not have the resources or the time to conduct an inquiry that would do justice to the recent events in Victoria's aged care homes, which continue to change and develop. An investigation of the Victorian situation would have required us to impose upon aged care providers and the Victorian and Commonwealth governments in a way that would necessarily have distracted from their focus on the unfolding crisis. This would have been entirely inappropriate at this time. Because of this, we consider that it would be inappropriate for Council Assisting to refer by name to any Victorian providers, and we will not do so. This will only be appropriate in our view in an inquiry dedicated to investigating the circumstances in Victoria. And as explained in your statement, Commissioner Pagoni, it is a matter for government whether there is to be any separate inquiry into the situation in Victoria. This Royal Commission, of course, was not established to examine the impact of COVID-19 on the aged care sector. It was established in 2018 to examine the quality of aged care services provided to Australians, the extent and causes of substandard care, and what can be done to strengthen the system of aged care services to ensure the services are of high quality and safe. This hearing is part of that examination. It is not an inquiry into the causes of the deaths from COVID-19 in aged care facilities. That is the role of state coroners. This hearing will instead focus on the response to the COVID-19 pandemic in aged care and what can be learnt from this experience for responding to future pandemics, infectious disease outbreaks or other emergencies. The two principal areas of focus will be first, preparedness, and second, balancing infection control with quality of life. The hearing will include consideration of the role and responsibilities of state, territory and federal governments in responding to such crises in aged care services, what should be done and by whom in the future to support the aged care sector to respond to pandemics, infectious disease outbreaks or other emergencies, the balance between managing risks posed by a future pandemic or infectious disease outbreak and maintaining the overall health and wellbeing of aged care recipients, including their mental health and quality of life, the measures taken by the health and aged care sectors to respond to the pandemic, including transporting infected residents to hospital, the impact of those measures on older Australians receiving aged care services, their families and their carers, challenges faced by the aged care sector, including those relating to management, workforce and access to personal protective equipment and other related matters. Commissioners, the COVID-19 pandemic has starkly exposed all of the flaws of the aged care sector, which have been highlighted during this Royal Commission. Those flaws have been revealed by evidence led in the Royal Commission and were outlined in the interim report in October 2019. In light of those deficiencies, it is hardly surprising that the aged care sector has struggled to respond to COVID-19. As we explained in our submissions in February of this year, the de-skilling of the aged care workforce was identified as a likely consequence of the lack of regulation of staffing in aged care. For instance, the requirement for one registered nurse to be on duty in a home at all times was removed in 1998. As Professor Kathy Eager, Professor of Health Services Research at the Wollongong University, has been quoted as saying, most people would be surprised to know that you don't have to have a nurse on the staff to run a nursing home. The consequences of a shortage of clinical skills in aged care homes for care quality and resident safety have been demonstrated time and again in the case studies this Royal Commission has examined. The case studies have shown the consequences of a system in which providers have the ultimate say concerning the numbers and skill mix of their workforce and can choose between paying the hourly rate of a university-educated nurse and that of a care worker with or without a Certificate 3. Successive inquiries have identified the gradual erosion in clinical skills in the residential care sector. Proposals to introduce minimum resident to staffing ratios, such as we have in public hospitals, childcare and public sector residential aged care, have been resisted by both the Commonwealth Government and the sector alike, including during this Royal Commission. It can be said, Commissioners, that the aged care system we have in 2020 is not a system that is failing. It's the system operating as it was designed to operate. We should not be surprised at the results. Commissioners, since your call for submissions on 28 April 2020, we have received 364 submissions concerning COVID-19 and its effects on the aged care sector. Submissions have been made by concerned family members, people receiving aged care services, aged care providers, people working in aged care, people providing frontline health services, governments and various peak bodies. Submissions have been received from across the country, with the greatest number coming from people based in New South Wales, followed by Victoria. The last week before submissions closed on general matters also saw a sharp increase in submissions from each of these states. In addition to written submissions, the Office of the Royal Commission has fielded 87 telephone inquiries directed to concerns about the impact of COVID-19 on the aged care sector. These submissions are a window through which we can see the effect of the pandemic on aged care residents. They reveal the extent of concern about the impact of COVID-19 and about the measures put in place to protect those receiving care. Many of the submissions were received before the situation in Victoria escalated, a situation all of us have been watching with grave concern. Many of the issues raised in submissions have been aired in the media. However, they warrant briefly being repeated. Isolation is the strongest theme running through the submissions, with people raising concerns about being unable to visit loved ones and the effect of a loss of social interaction, including through the reduced or modified activities in residential care services. Commissioners, in submissions you've been told about spouses and children cut off from their parents and partners, unable to support their care in the way they did before the pandemic. It is unsurprising, perhaps, that after isolation, it is concern about unmet needs of care recipients that is the next most common theme in the submissions. Concerns are also raised about nutrition, hydration, medication management and access to allied health services. The submissions remind us that the aged care workforce faces significant pressure. As well as low staff numbers and a casualised workforce, they refer to inadequate training on infection control and inadequate access to and training in the proper use of personal protective equipment. Workers have been criticised for doing, they say, the best they can in the most difficult circumstances the aged care sector has confronted. Confusion about and interpretation of guidelines is another clear theme in the submissions, as too is the confused and inconsistent messaging from providers, state and federal governments, begging the question, who is in charge? The submissions you've received clearly demonstrate that the issue of COVID-19 and its impact on those receiving aged care services, their loved ones, and on the sector itself is at the forefront of the community's mind. Commissioners, direct experience witnesses have been an important part of all of the Royal Commission's hearings. Today you'll hear from Merle Mitchell, who's an aged care resident in Victoria. Ms Mitchell will give evidence about the impact the restrictions on visitors have had on the mental health of residents. Since her facility was locked down in February this year, she has only seen her daughter twice in person, once in a room with a glass partition and once through a window on her birthday. Tomorrow you'll hear from Ms Virginia Clark, whose father passed away in April from COVID-19 at Newmarch House, where he'd lived since 2013. Ms Clark will say she was generally happy with the communication from the provider until March of this year. She will describe the impact on her father of the lockdown, which commenced on 23 March 2020. And she'll explain that on the day before her father passed away, she was asked to update his end-of-life form. She will explain that she spoke to her father about whether he wanted to be transferred to hospital and the dilemma this caused. And she will say that she does not think her father was even told that he was COVID-19 positive. Ms Clark makes a number of suggestions for the future based on her experience. The third direct experience witness has been given the pseudonym of UY. UY is the eldest daughter of an Italian man with motor neurone disease who entered residential aged care in June 2019. She will explain that her father had high care needs, was non-verbal and had mild dementia. UY will describe the impact on her father of the lockdown that was instituted at the home in response to the pandemic. Her daily visits had to be conducted through a window, which caused her father great anxiety and confusion. UY will explain that her father deteriorated quickly and on 6 June went to sleep for 6 days and passed away. She also reflects on her experience and makes recommendations about improvements. How well prepared is the Australian aged care sector for COVID-19? On 29 July 2020, as COVID-19 was raging through a large number of nursing homes in Melbourne with devastating consequences, Commonwealth Health Minister Greg Hunt was quoted as saying that, and I quote, "Aged care around the country has been immensely prepared," end quote. We'll be scrutinising how well prepared aged care actually is to cope with the pandemic. As we'll shortly explain, in a number of important respects, the evidence will demonstrate that the sector has been underprepared. While we readily acknowledge that COVID-19 presents an enormous challenge to governments and the aged care sector that in many respects is unprecedented, we'll be asking if greater attention to preparation may have saved lives and could save lives in the future. This pandemic is clearly here to stay for the foreseeable future. It is of the utmost importance that those overseeing the aged care sector and those operating it learn all they can so that they have the weapons for the fight. While there was undoubtedly a great deal done to prepare the Australian health sector more generally for the pandemic, the evidence will reveal that neither the Commonwealth Department of Health nor the aged care regulator developed a COVID-19 plan specifically for the aged care sector. Professor Joseph Ibrahim, a specialist medical practitioner in geriatric medicine and Professor of Forensic Medicine at Monash University, has been researching the Australian aged care sector for 2 decades. He'll give evidence on Wednesday. Professor Ibrahim will say that there needed to be an articulated strategy for the aged care sector which drew on and coordinated national expertise about infection control and the sector. Such a strategy would have identified the gaps in the aged care system and the likely limits on its ability to cope with the pandemic. The Australian healthcare sector's COVID-19 emergency response plan of 7 February 2020 made little reference to the aged care sector and the particular vulnerability of its residents. It noted that additional strategies may be required to support at-risk groups, including aged care. Professor Ibrahim's evidence will be that there was insufficient consideration of the particular vulnerabilities of the aged care sector in the country's COVID-19 planning early in 2020. He will say that among the steps that should have occurred were A, a national audit of all residential aged care facilities to judge their level of preparedness, B, proper dissemination of the lessons to be learnt from the outbreaks in Sydney homes in March and April 2020, and a systematic approach to providing clear clinical and infectious diseases advice to residential aged care facilities through a national coordinating body established for this purpose. The Australian Health Protection Principal Committee, AHPPC, is the main source of advice about COVID-19 in Australia. The committee released 45 COVID-19 statements between 17 March and 3 August of this year. A statement released on 17 March 2020 gave general advice to a number of sectors, including residential aged care. There have been 3 statements specifically directed at the aged care sector since that time, 21 April, 19 June and 3 August. By comparison, there have been 8 statements about children and schools in the same period. Commissioners, before its statement about the Victorian aged care sector dated 3 August 2020, the most recent aged care statement from this committee was on 19 June 2020. That statement provided advice about the need to loosen the restrictions on visitor access, and I quote, based on the low levels of local transmission, end quote, of the virus. As the committee noted in an update 2 days later on the 21st of June 2020, community transmission of the virus increased steadily in Victoria from mid-June 2020. However, there was no updated advice for the aged care sector from the committee between 19 June 2020 and 3 August 2020, a crucial period of 6 weeks during which the number of new daily infections in Victoria grew from 25 to 413. There was no advice about how the sector should respond to the risk posed by aged care workers who may be COVID-19 positive yet asymptomatic, particularly those who work in multiple facilities. Commissioners, we readily acknowledge that the Commonwealth Department of Health has released many updates and has hosted webinars for the aged care sector concerning COVID-19 since 31 January 2020. Many of these contain very valuable general information, and no doubt they have assisted providers to prepare for an outbreak. The department drew to the attention of providers in early March 2020 the guidelines for responding to COVID-19 in aged care facilities prepared by the Communicable Diseases Network Australia, which included much useful information to help them prepare for the pandemic. However, in light of the very high stakes for residents in aged care homes, we'll be asking whether everything that could have been done to protect them was done. In particular, we'll be focusing on the 2 aged care outbreaks in Sydney earlier this year and asking if the lessons that emerged from them have been appropriately distilled and conveyed to the sector. So what was done to prepare the sector? What has the aged care regulator done? Its statutory functions include educating the sector and monitoring its performance. Commissioners, as you're well aware, the Aged Care Quality and Safety Commission was established in January 2019, and its responsibilities and powers were expanded at the start of this year. Commissioner Janet Anderson has provided us with a statement and will give evidence on Wednesday. Commissioner Anderson has a range of functions, including to educate and inform approved providers of aged care services about their responsibilities and to monitor the quality of care they provide. The Commissioner has statutory powers and as at 30 June 2019 had 472 staff. And since May of 2019, the Commission has had the benefit of a Chief Clinical Advisor, Dr. Melanie Roth, from whom you will also hear on Wednesday. Regulating the aged care sector as it confronts COVID-19 has been and continues to be this regulator's biggest test. What did the Commissioner do to protect the sector, and what has she done by way of regulating the sector? We've already noted that the regulator did not have an appropriate aged care sector COVID-19 response plan. Given that it was widely understood that recipients of aged care services were a high-risk group, this seems surprising. On 17 March 2020, Ms Anderson wrote to all residential aged care providers and invited them to participate in a survey assessing their preparedness for an outbreak of COVID-19 in an aged care home they operated. Providers were asked to answer 23 questions, including, does the service have an infection control respiratory outbreak plan? Have staff at the service been educated on the policies and processes for all aspects of outbreak identification and management, particularly infection control? And does the service have a plan for communicating with staff, residents, volunteers, family members, and other service providers during an outbreak? And the services were also asked the general question, and I quote, overall, how would you rate the service's readiness in the event of a COVID-19 outbreak at the service? End quote. 2,345 residential aged care services responded to the survey. Operator, please display tab 9 from the general tender bundle at page 0008. A report of the survey dated 20 May 2020, part of which is displayed on the screen now, was prepared, although it may be the case that the regulator had the results earlier than that date. According to the report, 99.3% of services said they had an infection control respiratory outbreak plan. 92.6% of services said that staff at the service had been educated on the policies and processes for all aspects of outbreak identification and management, particularly infection control. 99.5% of services said they had a plan for communicating with staff, residents, volunteers, family members, and other service providers during an outbreak. And operator, if you could please focus on the pie chart on page 8, which I think is, yes, that's it. Thank you, if that could be expanded. 99.5%, depicted by the purple component of the pie chart, claimed that their infection control respiratory outbreak management plan covered all areas identified in the survey. And 99.5% of services, if you could go to the pie chart on the following page, please. One at the bottom of the page. That's it, thank you. 99.5% of services assessed their services readiness in the event of a COVID-19 outbreak as either satisfactory, 56.8%, that's the blue part of that pie chart, or best practice, 42.7%, that's the green part. Only 0.5% of services considered they were in need of improvement. Commissioners, we anticipate that Professor Ibrahim will be highly critical of this survey. He will say that too much knowledge on the part of providers was assumed in the questions. We will ask Commissioner Anderson what lessons can be learned from the survey's very optimistic and positive responses. In light of subsequent events and given the regulatory action taken by the Commissioner against Newmarch House's operator on 6 May 2020, were the sector's views about its state of readiness realistic? Was the sector properly informed about what readiness for an outbreak of COVID-19 actually involved? And what lessons can be learned about this for the future? Commissioners, Dorothy Henderson Lodge in Sydney was the first Australian aged care home to experience a COVID-19 outbreak. It's an 80-bed facility which employed 78 staff. On 3rd of March 2020, a personal care worker employed by Baptist Care, the provider which ran the home, was diagnosed as COVID-19 positive. Within 2 days, 4 residents and 2 more staff had tested positive. By the time the outbreak was declared over on 7 May 2020, 16 residents had tested positive, of whom 6 had passed away. 5 staff members who'd contracted the virus all recovered. No regulatory action was taken against the provider. On the 11th of April 2020, a staff member employed by Anglicare Sydney at Newmarch House in Sydney tested positive for COVID-19. Newmarch House had 89 occupants. By 15 June 2020, when that outbreak was declared contained, 37 had tested positive and 17 had died of COVID-19. The 34 staff who tested positive have all recovered. On 6 May 2020, the Aged Care Quality and Safety Commissioner issued a statutory notice to Anglicare requiring it to agree in writing to 4 conditions within 24 hours. Failing agreement, Anglicare faced revocation of its approved provider status. The Commissioner had also taken earlier regulatory action against Anglicare on 23 April 2020. The notice to agree issued to Anglicare was justified by the regulator on the basis that there was, and I quote, an immediate and severe risk to the safety, health and wellbeing of care recipients at the service, end quote. The notice referred to concerns about whether the provider had suitable processes and systems in order to control transmission of the virus at the service. Commissioners, we note that at its most recent accreditation audit in September 2018, Newmarch House had passed all 44 expected outcomes, including 4.7 infection control. And it was one of the providers that had rated itself as best practice in the survey in March. By the time the regulatory action was taken on the 6th of May, the outbreak at Newmarch House had been raging for over a month and 16 of the residents had passed away. The evidence of Dr. Branley, who treated many of the residents at Newmarch House, will be that infection control processes and the staffing situation had improved considerably by early May compared to earlier in the response. We will ask why the regulator acted when it did. Was the regulatory action too little, too late? You'll hear from a number of people who responded to these 2 outbreaks. You'll also hear about reports by experts in infection control that have been prepared, which have examined the responses of the providers to the outbreaks. 2 reports into the Dorothy Henderson Lodge outbreak were completed in mid-April. There are 3 reports into the Newmarch House outbreak, and the evidence will be that 3 further reports are in preparation. You will also hear from senior managers at both Dorothy Henderson Lodge and Newmarch House. The managers will describe what worked well and where they had difficulties. Before outlining some issues discussed in the reports, we note that media reports in recent weeks have described webinars at which the Aged Care Minister has responded to the concerns of family members of residents in care homes in Melbourne facing outbreaks. In at least one case, the Minister was asked if an investigation would be conducted into the circumstances. It may come as a surprise to some that the aged care regulator has not investigated the circumstances of the Dorothy Henderson Lodge and Newmarch House outbreaks. Incident investigations are normally one of the key tasks of any regulator for obvious reasons. An investigation into the facts can inform future regulatory action and policy development. In light of the ABC's Four Corners program about Newmarch House in June of this year, Mr Yates of COTA called for the aged care regulator to be given greater powers of investigation. We also have concerns about whether the regulator's powers of investigation are adequate. For example, the regulator's authorised officers are only able to enter the premises of a provider with the provider's consent, and any consent may be refused or withdrawn without the need for a reason. Even when aged care authorised officers enter a care home, any questions they ask are not required to be answered. A person asked a question may refuse to answer it. They're not required to have a reason for doing so. Similar limitations are imposed on regulatory officials exercising powers for a regulatory purpose. And while such officials are granted broad search powers under the Aged Care Quality and Safety Commission Act, those powers may be rendered nugatory by the withdrawal of consent for the official to be on the premises. Comparable regulators in fields such as workplace or airline safety have no such limitations on their powers. And it's not as if these statutory provisions have sat on the statute books for decades waiting to be modernised. The Act establishing this regulator was passed on the eve of this Royal Commission. The limits on the regulator's powers reflect contemporary government policy. We will explore with Commissioner Anderson whether the reason for her failure to investigate the outbreaks is explained by deficiencies in her powers or some other reason. Commissioners, we surely have no hope of fighting COVID-19 and protecting the residents in our nursing homes if the various levels of our governments are not working together. There are notorious problems associated with the relationship between the health system, which is run by the states, and the Commonwealth-run aged care sector. These so-called interface issues were always going to be brought into stark relief by an outbreak of COVID-19 in the residential aged care sector. Was sufficient planning undertaken for how the interface would operate in the event of such an outbreak? Who would call the shots? For example, who would decide when it is appropriate for a COVID-19 positive resident to be transferred from an aged care home, which falls under the jurisdiction of the Commonwealth, to a hospital which falls under the state system? And in what circumstances and by what process would the state's expert infection control resources be made available to Commonwealth-funded homes? Subsequent events, including the response to the Newmarch House outbreak, suggest that these and many related questions were not adequately addressed in planning. They should have been. In his statement, the Chief Executive Officer of Anglicare, Mr Millard, says that, at least initially, the roles and responsibilities of the various state and Commonwealth authorities assisting Anglicare to respond to the Newmarch House outbreak were unclear. He says there was often confusion about designation and decision-making authority. Specifically, it was unclear who had the authority to resolve disputes about crucial questions of clinical care, including whether residents should be relocated. In the report Mr Millard provided to Anglicare's board on 6th of May 2020, he said, and I quote, "Over the course of the outbreak, there has been a frustrating level of dysfunction in the collaboration between Newmarch House Anglicare management and the numerous government departments, agencies and hospital employees at both federal and state level with an interest in management of the outbreak." He went on, and I quote, "Anglicare has looked to these authorities for their expert advice in dealing with the outbreak, but this advice has often been conflicting. Further, there is a lack of clarity regarding which of these authorities has responsibility for decisions and how this authority intersects with Anglicare's responsibilities under the Aged Care Act to manage the home." Mr Millard's perception is consistent with the contemporaneous emails and notes that have been examined by the staff of the Royal Commission and that are included in the Newmarch tender bundle. By contrast, the evidence of Mr Lai of the Commonwealth Department of Health will be that he did not consider there was any lack of clarity about roles and responsibilities. That perceptions about this central question on the part of two of the major players involved in the Newmarch outbreak could be so different is itself a cause for concern. Commissioners, it's difficult to learn a lesson if you don't think there's one to learn. The hearing will explore this difference of opinion and what has been done subsequently to ensure that providers are clear about this important topic. What does the experience of Newmarch House tell us about how well the Commonwealth and New South Wales governments work together? What were the lessons? Were they disseminated to other providers and to other states and territories? Why was there no Commonwealth State Aged Care Forum at which the lessons were discussed and shared? We will ask Professor Ibrahim if the national coordinating body that he proposes could have been such a forum. And has the protocol that was established between the Commonwealth and New South Wales governments after the Newmarch House outbreak been replicated in other states? What practical steps have been taken to ensure any mistakes made in New South Wales are not repeated elsewhere? Commissioners, a vexed issue since the pandemic first emerged in aged care in Australia in March has been the extent to which there should be limits imposed on visitors to aged care homes. Family members and friends provide great comfort to residents and often help with feeding and other care needs. This is partly a reflection of the staffing shortages in many homes. As noted, the direct experience witnesses from whom you will hear will describe the anguish they and their relatives suffered as a result of limitations on visiting rights. The earliest advice to the sector from the regulator about visitors was dated 23 March 2020 and referred providers to the advice dated 17 March 2020 from the Australian Health Protection Principal Committee. That advice was to impose a range of limitations, including limiting visitors to a maximum of 2 visitors at one time per day. The letter from the regulator stressed the need to apply these restrictions with compassion and care, and to be proactive in identifying and minimising other risks that may arise to residents as a result, such as where family members assist at mealtime. The response of the sector, perhaps not surprisingly, in light of the first outbreak at Dorothy Henderson Lodge, was to impose far stricter limits on visitors. For example, Newmarch House excluded all visitors on 23 March 2020. Other providers, though, adopted a more nuanced approach, which did not involve banning visitors outright. For example, you will hear from Dr. Stephen Judd, the CEO of Hammond Care, that Hammond Care appointed a concierge service to screen visitors. He will explain that this approach sought to balance the risk of COVID-19 infection against the risk to vulnerable older people that would arise as a result of them being isolated for an extended period. The issue of visitors came to a head when the Prime Minister spoke in April of the importance of aged care visits and threatened the sector that new regulations would be imposed requiring them to open their homes to visitors if they did not lift restrictions. This in turn resulted in an industry code for visiting residential aged care homes during COVID-19, which sought to strike a balance between the risks of COVID-19 and loneliness. The first version of this code was dated 11 May 2020. While encouraging providers to allow greater visitation rights, the code acknowledged that it would be appropriate for the rules to be tightened when an outbreak occurs in the home or a declared outbreak clusters have occurred within the home's local area. A review of the code on 29 May 2020 noted that, and I quote, "In response to the code, there has been a stark improvement and increase in the availability of visits to residents, while still ensuring that residents are protected from COVID-19 by strict procedures to safeguard their safety," end quote. As noted earlier, the Australian Health Protection Principal Committee advised on 19 June 2020 that there should be a further relaxation of restrictions and that there was no need for staff to supervise visits. No advice was provided at that time about the need for visitors to wear masks. Commissioners, we will explore the difficult questions that arise in seeking to balance protection of the physical health of residents while also recognising the importance of mental health and general quality of life. We readily accept these are complex issues. Commissioners, one of the strong themes that emerges from the reports into both the Dorothy Henderson Lodge and the Newmarch House outbreaks is the importance of infection control expertise. At Dorothy Henderson, Ms Cathy Dempsey from the New South Wales Clinical Excellence Commission and another expert in infection control were deployed on day one of the outbreak. They provided advice and training to staff about personal protective equipment use. They monitored progress and assisted in the de-escalation plan at the end of the outbreak. You'll hear from Ms Cathy Dempsey. Witnesses from the home's operator, Baptist Care, will describe this help as invaluable. You will hear that the position at Newmarch House, however, was quite different. There was a lack of high-level infection control expertise until at least 2 weeks into the outbreak. The lessons were and remain clear. We must have a mechanism to get this expertise on the ground on day one in any home with an outbreak. Commissioners, infection control should be core business for aged care facilities. Hong Kong, which has been one of the best performers in the world in its response to COVID-19 in long-term care homes, has required government-trained infection control officers to be employed in care homes since the SARS outbreak in 2003. The need for a dedicated infection control manager in all Australian nursing homes was recognised in a 2012 coronial inquest in Victoria. After a lengthy and thorough inquest into the deaths of 4 residents from gastroenteritis at a Melbourne aged care home, then State Coroner Jennifer Coate recommended that the Victorian Department of Health, in consultation with what was then called the Commonwealth Department of Health and Ageing, require aged care facilities to have a designated infection control manager. Commissioners, based on the evidence at this Royal Commission to date, it's not apparent to us that this recommendation was implemented across the sector. There are undoubtedly providers with excellent infection control systems, but there are also a number that have systems to deal with influenza and gastro that are not robust enough to deal with a COVID-19 outbreak. We will ask witnesses about that and about the broader question of what processes those in charge of the aged care sector have for responding to coronial recommendations generally. If they don't systematically respond to such recommendations, it can hardly be a surprise that we don't have an aged care system that meets the community's expectations. Commissioners, a report dated 14 April 2020 by Professor Lynn Gilbert, a senior researcher at the Marie Bashir Institute for Infectious Diseases and Biosecurity, into the response at Dorothy Henderson Lodge included the following advice, and I quote, "Access to an experienced infection prevention and control specialist was critical in this outbreak, but may not be available to all aged care facilities, especially at short notice. Ideally, COVID-19 outbreak management plans for individual aged care facilities should be developed in advance with the assistance of an infection prevention and control professional and/or an infectious disease specialist. It should be based on context-specific risk assessment." End quote. Professor Gilbert's report then set out the details of what such an assessment should cover. There have been media reports, Commissioners, that this report has not been made public. It should have been published as it contains a number of important lessons to help the aged care sector. It should not be the task of Council assisting this Royal Commission to make such a report public, but we readily do so, and we've included it in the Dorothy Henderson Lodge tender bundle, which I will shortly tender. A report of high-level infection control review concerning the Newmarch House outbreak was produced on 1 May 2020, also by Ms Cathy Dempsey. Ms Dempsey's report concluded that the dedication and commitment of the staff and management were outstanding, and that the report she produced was not intended to be a reflection on their effort. However, excuse me, the report did, and I quote, provide an opportunity to review an approach when providing increased staff and external staff. The overall governance, including at a clinical level, needs careful consideration, planning and execution. Ms Dempsey's report continued with the observation that, and I quote, "The presence of infection prevention and control practitioner early on in an outbreak that can be on site, coordinating, managing, educating and working with public health cannot be underestimated in these circumstances." Commissioners will be asking what steps those who oversee the aged care sector are taking to disseminate the findings and recommendations of these reports to the sector. For example, are they checking to see if providers have COVID-19 management plans that meet the stipulations of Professor Gilbert? Have providers been informed by the Department of Health of Professor Gilbert's recommendations? Has Professor Gilbert been asked to prepare a template plan that could be adapted for use of individual facilities? And are providers being educated about how to implement such a plan and who is responsible for providing this education? Specifically, Commissioners, what steps are being taken by those in charge of the aged care sector to source infection prevention and control experts as proposed by Ms Dempsey in her report dated 1 May 2020? Such experts could be deployed at short notice to nursing homes facing a COVID-19 outbreak. Such experts generally work for state health departments and in our universities and our world-class research centres. Has a list been prepared and are relevant contact details given to providers? If the Commonwealth can directly engage aged care employment providers such as Mabel and Aspen, why is it not engaging infection control experts? These are all matters that the National Coordination Body proposed by Professor Ibrahim could have addressed earlier this year. They should be addressed immediately. Commissioners, a crucial part of the management of any crisis is communication. In the context of COVID-19, an aged care provider must communicate clearly and openly with its residents and their families. A particularly concerning aspect of the Newmarch House response was poor communication. We all saw the images on the news of relatives camped outside Newmarch House in April, seeking the most basic information about their loved ones. Tragically, we've seen similar scenes outside homes during the recent outbreaks in Melbourne. Once again, some families have been unable to ascertain even whether their loved ones are alive or dead. That this can happen in Australia in 2020 is unacceptable. That it is happening again so soon after Newmarch House is unforgivable. It is to be recalled, Commissioners, that when providers were asked by Commissioner Anderson to self-assess their preparedness for COVID-19 in March, 99.5% told the regulator they had a plan for communicating with family members and residents during an outbreak. Newmarch was no exception. We'll examine, Commissioners, what was done by authorities in the sector after Newmarch to ensure that basic communication by providers was improved. Has the lesson been learnt that having a written plan is one thing, but whether it can be implemented in a crisis in a humane manner is the real test? During both the Newmarch House and Dorothy Henderson Lodge outbreaks, there were problems with sourcing and the correct use of personal protective equipment, PPE. Our first witness, Professor of Epidemiology at the University of New South Wales, Professor Mary Louise McClaws, will explain the necessity of PPE for responding to a COVID-19 outbreak and its correct use. She'll explain that infection control requires a high degree of vigilance, and an infection control system will only be as good as its weakest link. Mr Millard of Anglicare will explain the significant difficulty that Newmarch House had in securing the PPE it needed. He found accessing PPE incredibly challenging and very stressful for his already stretched workforce. Concerns about access to and the correct use of PPE have been raised in both the Australian Nursing and Midwifery Federation's May survey of aged care nurses and the United Workers Union's June survey of its members in aged care. Those surveys paint a different picture of the sector's state of readiness to that included in the provider survey. Did the results cause policymakers to consider if PPE training should be made compulsory? And if not, why not? And is the training in PPE use that has been made available by the Commonwealth appropriate? Professor Ibrahim will raise concerns about its effectiveness. And quite apart from the quality of the training, what proportion of care workers have actually completed it? Commissioners, a policy of transferring COVID-19 positive patients to hospital was followed at Dorothy Henderson Lodge. 13 of the 16 residents who had tested positive were sent to hospital. Of the remaining 3, 1 did not want to go to hospital and was palliated at the home. The remaining 2 recovered. We anticipate that Mr Lowe and Ms Dix of Baptist Care will say that hospitalisation of positive residents at the early stages made the process of responding to the outbreak a little easier while they were stabilising their staffing. By contrast, at Newmarch House, residents were treated pursuant to a policy known as hospital in the home. There was a vigorous disagreement between the Commonwealth and New South Wales officials on this question of hospitalisation of COVID-19 positive residents in the early days of the outbreak at Newmarch House. An email dated 15 April 2020, 4 days after the outbreak began, and at a time when there were 15 infections, including 9 residents, records the Chief Clinical Advisor to the Aged Care Regulator, Dr Melanie Roth, and I quote, strongly recommending that infected residents be removed from the site, end quote. She inquired if the department could offer a separate location, for example, through the private hospital funding initiative. She also noted that the issue would grow as more positive test outcomes are expected. Another email dated 16 April 2020 records a meeting of the Commonwealth and New South Wales officials. According to that email, at the meeting, Ms Amy Laffin, Acting First Assistant Secretary of the Commonwealth Department of Health, said the Commonwealth was, and I quote, keen to understand whether hospital beds could be used for residents of Newmarch to ensure appropriate care is being provided, end quote, a process referred to by health officials as decanting residents. The following words appear next to the words New South Wales Health in the email. I quote, preference is not to decant residents into hospitals, given the precedent this would set. Need to find solutions that enable appropriate care to be provided in the facility. Looking at hospital in the home and in-reach palliative care if needed, end quote. Dr Roth's views were supported by the Aged Care Quality and Safety Commissioner, Ms Anderson. The Commissioner wrote in an email to the Commonwealth Department of Health, also on the 16th of April 2020, after the meeting at which the New South Wales Ministry of Health raised the concern about setting a precedent, and I quote, Commissioner said, we must be vigilant in calling out the elephant in the room if ever we sense it might be present. To be clearer, if there is a view sitting behind the New South Wales Health position that aged care residents with COVID-19 should always be cared for in situ and should not be transferred to a hospital in any circumstances, then we must call this out as an intolerable and unsupportable assumption, end quote. Commissioners, we hope to understand what the precedent was that was concerning the New South Wales officials. You will hear from Dr Nigel Lyons, a senior official from New South Wales Health, who was at that meeting. Commissioners, equal access to the hospital system is the fundamental right of all Australians, young or old, and regardless of where they live. Many of the residents in aged care homes work their entire lives to build the world-class health system of which Australians are justifiably proud. They have the same right to access it in their hour of need as the rest of the community. To put it very directly, older people are not less deserving of hospital treatment because they are old. Such an approach is ageist. The evidence of Mr Millard will be that this standoff between Commonwealth and New South Wales officials was so concerning that he spoke to the Federal Aged Care Minister, Senator Colbeck, about it. He was subsequently told by the Minister's Department to follow the New South Wales Health Department's advice. And on the following day, the New South Wales Health View held sway. All residents at Newmarch House were treated as part of hospital in the home. This was despite the preconditions in the relevant guidance material, such as a written agreement between the hospital and the home and training for the home staff, appearing not to have been completed. We will explore if this is the best process for resolving disagreements between various levels of government. Who should have the final say on the question of whether a COVID-19 positive resident is transferred to hospital? And is hospital in the home the best way of responding to an outbreak of COVID-19 in an aged care home? And if it is, what more needs to be done to prepare those homes for its implementation? According to Mr Millard, of the 37 residents who tested positive to COVID-19 at Newmarch House, only 2 were transferred to hospital. One of those died. The other 16 residents who died of COVID-19 were all treated at Newmarch House. Mr Millard's evidence is expected to be that Anglicare had little or no say about whether COVID-19 positive residents should be transferred to hospital for care. Commissioners, there's a real question of whether any provider is capable of meeting its requirements under the Aged Care Act in responding to an outbreak of COVID-19 without ready access to the hospital system. That was the conclusion of Mr Millard when he had a chance to reflect on the Newmarch House experience. He told the Anglicare Board on the 27th of May 2020, and I quote, "In the event of infection at another Anglicare home, Anglicare would be far more assertive regarding the most appropriate management of COVID-19 positive residents and would strongly push for these residents to be immediately transferred to hospital." End quote. We will ask Mr Millard why Anglicare was not more assertive in April and what are the lessons of that experience for other providers. In addition to the question of whether residents can receive the best medical treatment in a residential aged care facility, there's the important question of how a provider can meet its work health and safety obligations to its employees in such circumstances. And you'll recall that 34 staff members at Newmarch House also tested positive to COVID-19. Commissioners' views among experts and state health departments vary on the question of whether to hospitalise residents who test positive to COVID-19. Professor McLaws will say of aged care residents who are COVID-19 positive that, quote, transfer to hospital is the only appropriate solution that may improve their survival rate and reduce the risk of infection in the remainder of residents, end quote. Dr Branley, who treated a number of the residents at Newmarch House, considers that such an approach is not in accordance with best practice. Now, the difference of opinion may be explained by the different perspectives of Professor McLaws and Dr Branley. Professor McLaws is an epidemiologist with a broad public health perspective. Dr Branley is an infectious diseases doctor with a focus on what is clinically indicated for individual patients. We will explore these different perspectives. South Australia's Health Department has a policy of automatic hospitalisation, and its Chief Health Officer, Professor Spurrier, who's part of the first panel this morning, will say that that's the most appropriate public health response, having regard to the limited capacity of nursing homes to implement high standard infection control. By contrast, the approach in New South Wales is to treat residents on a case-by-case basis. Commissioners, one effect of an outbreak of COVID-19 in a residential care home is that a large proportion of the staff will need to be stood down temporarily, at least while they await test results and possibly for longer. Because of the importance of continuity of staffing to the quality of care, this has the potential to impact very badly on residents and their families. It must be well managed. Replacement staff who will have no familiarity with the service and its residents must be sourced and then inducted quickly but thoroughly. Care plans need to be quickly understood. As noted, the self-assessment survey to which we referred earlier asked providers if they had a plan in case up to 20 to 30% of staff are unable to present for work. 55% of facilities that responded, including Newmarch House, said they did. The remaining 45% they were developing one. That figure of 20 to 30% appears to have been derived from the guidelines produced on 13 March 2020 by the Communicable Diseases Network Australia. Those guidelines had been adapted from previous works on influenza outbreaks in residential aged care facilities. Mr Millard will say that in the lead up to Newmarch House outbreak, Anglicare took a conservative approach and planned to lose 30 to 40% of its staff during an outbreak. However, he will say that even this was a massive underestimate, which was totally unrealistic. Anglicare effectively had to stand down its entire workforce at Newmarch House after the outbreak in the middle of April. Mr Lowe, the CEO of Baptist Care, will say that Dorothy Henderson Lodge lost almost its entire workforce within 48 hours of that outbreak. Interestingly, Commissioners, the way they attracted agency staff to work at Dorothy Henderson Lodge was to offer them acute sector pay rates and other improved working conditions. Perhaps the solution to the workforce crisis in aged care is not that complex after all. Were these vital lessons about staffing disseminated to the sector? What systems are now in place? Mr Millard will tell you that he did not know that he would lose such a high proportion of his staff, but there's no reason why providers after Dorothy Henderson Lodge and Newmarch House should be left in the dark about this. It was not until 29 June 2020 that the Commonwealth Department of Health advised providers that 80 to 100% of their workforce may need to isolate in a major outbreak. And even then, Commissioners, this information was located on page 5 of a 9-page document uploaded on 7 July 2020 on the Aged Care Regulator's website, with the intended audience identified as, quote, health sector, unquote. We note that a link to the document was included in a letter the Aged Care Minister wrote to providers on 7 July 2020. But until that advice was published, providers presumably relied on the estimate of 20 to 30% in the survey. Presumably their outbreak management plans were based on this erroneous information. Commissioners, regulators in other fields such as workplace safety publish one-page alerts to disseminate promptly vital safety information that they learn from incident investigations. We will explore with the Aged Care Regulator and the Department of Health whether they could do something similar. This question of staffing would have made a perfect example of how such an approach could work. An alert could have been published by the end of April at the latest, informing providers of the experiences of Anglicare and Baptist Care. Providers could have amended their preparedness plans accordingly. In his statement to this hearing, Mr Lai of the Commonwealth Department of Health explains that an important part of the Commonwealth's response to the COVID-19 pandemic has been sourcing additional staff for providers facing outbreak, called the surge workforce. After the Dorothy Henderson Lodge outbreak, contracts were entered into between the Commonwealth on the one hand and Mabel Technologies Proprietary Limited and Aspen Medical Proprietary Limited on the other. A total of 32 Mabel staff and 42 Aspen staff were paid by the Commonwealth to work at Newmarch House in response to the outbreak, at a total cost to the Commonwealth which exceeded $1.5 million. Mr Millard's statement tells you that while he was very impressed with the Aspen employees, it became quickly apparent to him that the Mabel workers did not have the skills and qualifications that were needed in the particular circumstances. Anglicare's concerns about Mabel were communicated to the Commonwealth Department of Health on the 17th of April 2020. How did the department respond? We will pursue that matter with Mr Lai. A further staffing-related issue arose at Newmarch House. It concerned aged care workers who worked at multiple facilities. This issue has attracted much attention in Melbourne in recent weeks, and there is media speculation that such workers may be the source of some of the infections in care homes. Mr Lai will explain that the Commonwealth Department of Health advised providers early this year, and I quote, health and aged care workers were able to continue to go to work at other services if they have had casual contact with COVID-19 cases and are well, and or have directly cared for confirmed cases while using PPE properly, provided they monitor themselves for symptoms and self-isolate if they become unwell, unquote. We will ask whether this advice adequately considered the position of a worker who may be COVID-19 positive, even though they are asymptomatic. In light of recent developments in Melbourne, this appears to be an important question. Finally, Commissioners, we note that the increase in community transmission of the virus in Melbourne in mid-June of this year led to the reintroduction of stage 3 restrictions and lockdowns of some public housing towers. Professor Ibrahim will say that the risk of an outbreak in an aged care home is extremely high, even with very low rates of community transmission. Daily new infection rates in Victoria rose from 20 on the 16th of June 2020 to 76 on the 30th of June 2020. However, masks were not made compulsory for aged care workers until 13 July 2020. That was 2 days after the first recorded death of an aged care resident in Victoria from COVID-19. By that date, the number of new infections in Victoria was 249. The risks of aged care workers inadvertently introducing COVID-19 into their workplaces had been clear since the Dorothy Henderson Lodge outbreak in March. What system was in place to monitor this increase in community transmission and consider appropriate responses to protect aged care residents? Why did authorities wait until after the first death to take what seems the simple and obvious step of making masks compulsory for aged care workers? If we had the sort of national coordinating body that Professor Ibrahim says should have been in place in March of this year, would the outcome have been different? And given that the experts all say that further cases of community transmission of the virus are quite likely, what are the lessons that can now be learned? Commissioners, before I call the first witness, I'll tender 3 tender bundles that contain documents to which reference will be made throughout the hearing. I would seek that they be marked separately, please, Commissioner Begoni. The first is the general tender bundle of 68 documents.
Yes, that'll be Exhibit 18-1.
The second is the Dorothy Henderson Lodge tender bundle of 15 documents.
18-2.
And the third is the Newmarch House tender bundle of 117 documents.
That'll be 18-3.
Commissioners, at this point, there are some appearances that are to be announced.
Yes, thank you.
May it please the Commission. Council appearing for Baptist Care, New South Wales, ACT, and also 2 Baptist Care was Mr. Lockhart.
I'm not sure that I could exactly hear that, but I take that to have been Mr. Lockhart announcing his appearance. Is that correct?
That's right.
Yes, thank you, Mr. Lockhart.
May it please the Commission, my name is England and I'm here with leave with my learned junior, Ms. Epstein, for Anglican Community Services, Mr. Grant Millard and Ms. Erica Roy.
Yes, thank you, Ms. England.
Please, you Commissioners, my name is Fordham. I appear for the State of New South Wales with my learned friend, Mr. Fraser.
Yes, Mr. Fordham.
May it please the Commission, my name is Dakey and I appear for the State of South Australia.
Yes, Ms. Dakey.
May it please the Commission, my name's Alistair McHugh and with leave I appear for Mabel.
Thank you, Mr. McHugh.
May it please the Commission, Morgan, my learned friend Mr. Arnott, I appear for the Commonwealth.
Yes, thank you, Ms. Morgan.
If it may please the Commissioners, my name is Jodie Burns and I'm from the Victorian Government Solicitor's Office and I represent the State of Victoria.
Yes, thank you, Ms. Burns. I think that completes them all, I think.
I think that's everyone. Commissioners, I note the time, and it was proposed that we would break for morning tea at 11:15. I'm in your hands, but it may be appropriate to do that now rather than just having 10 minutes with the first panel.
Well, the difficulty then is going to be the flow-on effect of taking up the time later on, isn't it?
It may be. I'm happy to. We'll catch up the time. I'm reasonably confident of that, or we could not have a morning break. In your hands.
Thank you, Commissioner Briggs. Would you like a shorter break now, or should we skip the break entirely?
I'd like to kick on if we could, please, Commissioner, but I think I might need a 5-minute break after the first witness, if that's possible, please.
All right, let's do that. Yes, thank you.
Thank you very much, Commissioner Briggs. Thank you, Commissioner Begoni. I call Professor Mary Louise McLaws and Professor Nicola Spuria, both of whom appear by video link.
Professor McLaws, do you swear by Almighty God that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say, I do.
I do.
Professor Spuria, Do you solemnly and sincerely declare and affirm that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say, I do.
I do.
Rosen.
Thank you, Commissioner. Professor McLaws, I'll start with you, if I could. Could you please state for the Royal Commission your full name? Can you hear me, Professor McLaws?
Oh, I couldn't then. You wanted me to state something and I didn't hear.
Yeah, sorry. Yeah, just your full name, an easy question to start with.
Oh, good. My name is Mary Louise McLaws.
Thank you. And Professor McLaws, you are Professor of Epidemiology, Healthcare, Infection and Infectious Diseases Control, School of Public Health and Community Medicine, Faculty of Medicine, University of New South Wales in Sydney.
Correct.
And you're also currently an advisor to the World Health Organization in its Health Emergency Program Experts Advisory Panel for Infection Prevention and Control Preparedness, Readiness and Response to COVID-19.
Correct.
And also part of the Infection Prevention and Control Guidance Development Group for COVID-19.
Correct.
And Professor McLaws, for the purposes of this Royal Commission hearing, have you prepared a précis of evidence dated the 22nd of July 2020?
I have.
And that appears at tab 2 of the witness materials. It's rcd.9999.0384.0001. Do you have a copy of that précis in front of you, Professor?
I do.
And have you had an opportunity to read through that before giving your evidence this morning?
I have.
And is there anything in it that you would like to change?
No, I think everything is fine. Yep.
And are the contents of that document true and correct?
Yes.
Commissioners, I tender the précis of evidence of Professor McLaws dated 22 July 2020.
Yes, that will be Exhibit 18-4.
If I could turn to you, Professor Spurrier. You are the Chief Health Officer for South Australia.
No, I'm the Chief Public Health Officer for South Australia.
Thank you. And for how long have you held that position?
Since August 2019.
You're a public health physician and a paediatrician?
Yes.
And you have worked for South Australian Health for 29 years?
Yes.
Presumably in a variety of other positions before your current appointment?
Yes, that's correct.
You're all, by virtue of your role in South Australia, you're a member of the Australian Health Protection Principal Committee?
Yes.
And that's chaired by the Commonwealth Chief Health Officer?
Yes.
And the solicitors acting for South Australia have been good enough to provide at very short notice a copy of your CV, which is rcd.9999.0430.0001. And I won't go through the remainder of that, but that should perhaps be tendered, or it's probably in the tender bundle, I think.
Sounds like it.
It will be in due course if it isn't presently. Mr. Spurrier, you haven't provided a witness statement or a précis, but the South Australian Department of Health has provided the Royal Commission with a general submission about COVID-19 and its impact on residential aged care facilities. Is that right?
Yes.
And I'll ask you about some of that in a moment, but for convenience, it's found in the general tender bundle at tab 27. Professor McLaws, if I could start with you, please, and ask you some, what are probably for you very basic questions about COVID-19, the nature of the virus and the methods of transmission. They're set out in some detail at paragraphs 2 and 3 of your précis. I won't ask you to read those out, but towards the bottom of paragraph 3, third line down in paragraph 3, you say this, and I quote, asymptomatic cases test positive for SARS-CoV-2 RNA for 1 to 2 weeks, while symptomatic cases with mild to moderate disease test positive at least 3 weeks, and severe cases for longer than 3 weeks. And that reference to SARS-CoV-2 is a reference to COVID-19 as the rest of us refer to it. Is that right?
Correct.
Yep. Continuing with what you say in paragraph 3, you say that this has implications for infection prevention for staff and prevention of transmission to residents, amount of personal protective equipment required dedicated staff, and continued environmental cleaning. Can I ask you in particular of what, in your opinion, are the implications for infection prevention of that observation that asymptomatic cases test positive for 1 to 2 weeks?
The asymptomatic proportion is difficult. It has been estimated anywhere between 13% and as much as 50, 60%, but that's often been done incorrectly because a number of facilities haven't been followed for 7 to 21 days to ensure that asymptomatics are truly asymptomatic and they're not in the pre-symptomatic phase. But the problem of asymptomatics, and let's say they're around somewhere between 20% to 30 or even greater, can be problematic because it means that they could be still shedding. Now, we've had 3 WHO meetings, first in February, one in July, and then one 2 weeks ago, where we still don't know the importance of asymptomatics for infection prevention and control. We're not sure how they drive the pandemic, let alone how they drive it within a built environment such as residential aged care facilities. But if all residents aren't tested on a regular basis, then you won't know how many are asymptomatic and positive and potentially shedding virus, which means that you won't know to put them away from other residents and other staff members.
Does that also have implications for staff members who may be COVID positive yet asymptomatic as well? Does that have policy
Correct.
implications for that cohort?
Correct, absolutely. And it's particularly important when you understand that workers, carers, often work across multiple facilities, not just in Australia, but worldwide. And it's usually because they're paid poorly. So if they do work across facilities, it is difficult to control the spread if they are asymptomatic as well. So they need to be tested regularly, but they also need to really wear face shield or face mask, or both, to ensure that they're not acquiring it and they're also not spreading disease to not just the residents, but also the visitors and other staff members.
All right, I'll come back to that issue in a moment if I could, but if I can just clarify one technical matter. You used the expression shedding. Can you just help us with understanding what that means in this context?
So you mostly acquire COVID from expiration, from people who are breathing out, but you can acquire it, of course, from saliva and sputum, and we think feces, but not as much, and not blood and not urine. So, of course, if the elderly don't swallow very well, they can build up saliva and they often touch their face, or their faces have to be wiped as well. So virus can be found in saliva and mucus that's coming out of a resident's mouth or nose.
Just ask you about a couple of other terms which are referred to in a number of the witness statements that have been provided to the Royal Commission. Firstly, the notion of the incubation period of the virus. Firstly, what is an incubation period of a virus? What does that mean?
So there are two periods that are important with COVID, as with any other infectious disease, and that is the incubation period and the serial interval. An incubation period is the time from exposure to a case to then developing symptoms. And that can be on average, for most people, 5 to 6 days. It can be up to 14 days, and in rare events, a little longer than that. The serial interval is when you become infectious to others. And new evidence is coming out that, of course, you're infectious potentially between day 3 and day 5 after exposure. So on average, 50% become infectious on day 4, and they haven't developed symptoms yet, which makes it difficult for infection control.
Two other matters I'd like to ask you about. Firstly, false positive tests for COVID-19. That is, someone who tests positive, but perhaps on later testing is found not to be positive. Is that a scenario that is common?
It's not common, but it can occur. It depends what tests are being used. In Australia, we don't use antibody tests, which have common problems. But mostly in Australia, the tests are looking for RNA. But that RNA can be live or it can be dead. So sometimes you can have a false positive. Sometimes you can have a false negative because it often depends exactly when you might do the test. And that's why you have to do tests commonly, potentially weekly for staff and for residents.
Probably anticipated my next question, which is the false negative test. That's a phenomenon of which you're familiar. I take it that can happen.
Yes, but it happens less often with the test that's used in Australia.
Right.
So if you test negative, the probability of you having a false negative is low.
Is the probability a little bit higher in relation to particular groups who may be difficult to test? So it has been said that some of the elderly residents of aged care facilities can, for a variety of reasons, be difficult to administer a test to. Does that mean that the rate of false negatives might perhaps be higher amongst that group?
Yes, that is true. Sometimes they find it difficult to have a swab put deep into the back of their throat or up their nose, particularly if they've got onset dementia or confused or anxious. And in fact, one of the symptoms that they've described in the elderly who weren't confused before they got COVID, but after they've got COVID or as they're becoming more symptomatic can be confusion as well, which makes it difficult to do the test.
One final matter for you, Professor McLaws, at the moment, that is you were asked some questions about the differences between COVID-19 on the one hand and infectious diseases such as gastroenteritis and influenza, which are commonly experienced in residential aged care facilities. And at paragraph 6 and 7 of your précis of evidence, you address that point. Are you able briefly to explain to the commissioners what the key differences are from an infection control point of view?
Well, with diarrhea, for example, the patient is obviously infected. They don't have a period where they're infectious to others. You mostly acquire this from small particles from feces, either as the staff member is cleaning up the resident or as they're flushing the toilet if they don't close the lid and it gets aerosolized. So it's easier to prevent infection transmission within an aged care facility if you're very careful about how you dispose of incontinence. With flu, still, some people get infectious at least 24 hours before they become symptomatic. However, with flu, staff are vaccinated, which cuts down the risk for staff of acquiring flu, but also the elderly and the visitors can be vaccinated. There is a small proportion of those who are vaccinated who never elicit an immune response, so they can still get influenza. So there's a small probability of transmitting it. But this disease is different, COVID, because you can't vaccinate it, and you can be infectious day 4 after exposure, having no symptoms at all.
Is the practical consequence of that difference, particularly the absence of vaccinations, or residents and staff and visitors who ought to be can be expected to be vaccinated against influenza? The significance of that is that infection control methods and processes necessarily need to be much more strict as part of a COVID-19 response than what might be necessary for influenza.
Yes, that's
right?
correct. Yes, that's correct. So there's no vaccine, so you have to be very stringent with environmental cleaning. You can catch COVID-19 from fomites, from high-touch areas that have been contaminated with the virus. That can happen also with influenza, but we believe influenza is mostly transmitted by small droplet nuclei that hang in the air for longer. But with this one, you can catch it from high-touch areas. The virus can live on hard surfaces such as metals and bed railings, for example, for up to 3 to 6 hours. It can be easily inactivated. However, that means constant cleaning of the environment, good hand hygiene constantly with soap and water or alcohol-based hand rub works very well, inactivates the virus. But you have to have very good training. Even in hospitals, some of my research shows that when healthcare workers, highly trained nurses and doctors are thinking high order medicine and nursing, they fail to hand hygiene at the 80% required rate, and sometimes fail and can hand hygiene as low as 50% of the time or even 30% of the time. So you've got workers, carers that are basically caring for the elderly as if they are family members, and they don't see a risk between themselves and the elderly necessarily. They've got a bond, and they may fail to hand hygiene as often and as scrupulously. So it takes a lot of training and awareness. Then, of course, you can acquire COVID in the air, particularly if the air is still and there's not a lot of airflow change. And in hospitals, the airflow change needs to be at least 40 to 80 litres per second per patient. And in most homes, it's nowhere near that. Sometimes it's even less than 3 litres per second per person in a home. And residential aged care facilities are basically a shared home. They may have heating to keep the levels of temperature at a comfortable rate. They won't be opening up windows to get good airflow and decontamination, as is often suggested in offices and dental practices and the like, if they don't have the airflow that hospitals have where they will be looking after COVID patients. So it is very difficult to decontaminate air. Although we believe that you catch this mostly from droplet-sized particles, it is not unreasonable to expect that there's a mixture of sized particles. We're not sure how important the smaller particle size is, but they're the ones that hang in the air for longer. So you do really need good airflow change. That may not be possible in some of the older built environments for residential aged care facilities.
Thank you. Professor Spurrier, you've been waiting very patiently there whilst I've been talking to Professor McLaws. If I could bring you in to this discussion, and particularly if I can ask you about the implications of that, the developing science that you've heard Professor McLaws talk about. And I assume you accept that through the course of the year, the science has been developing, that we've learnt more. We collectively have learnt more about the virus. What I want to ask you about is, from a public health perspective, applying the precautionary principle. What does that mean at a high level in terms of an appropriate public health response? Perhaps you could start by explaining to us the meaning of the precautionary principle in this context, and then give us some understanding of its application in relation to COVID-19.
Yes, thank you. So I'll just describe the precautionary principle, but I also had a slightly different opinion to a couple of things that Professor McLaw's raised, which I'd like to also address. So in terms of the precautionary principle, basically in public health, we often do things that may not appear from the general public's perception to be necessary. And I guess what we are trying to do is weigh up risk. So it's always looking at the risk involved in a particular setting, and then trying to make a valued judgment using science as much as possible to err on the side of caution. And that is in terms of making sure that we're keeping as many people healthy in a population as possible, or or if you're focused on a particular part of the community, that number of people as much as possible. So it's always staying on that rather cautious side. Now, this can become, of course, difficult when you've got different requirements from different parts of our society, and also there are a variety of things that can make people ill, and particularly with this pandemic. On the one hand, we are trying to reduce the spread of the virus, and the reason is obviously we want to save lives, but by doing that, one of the ways we do that is by restricting people's movements, and we've had to put restrictions on businesses. That has an obvious effect on reducing people's livelihood and restricting our economy, which in itself, of course, makes people ill. So it is quite a difficult challenge in public health, but the precautionary principle is basically erring on the side of caution when you may not have all the evidence. And as you inferred in your introductory remarks, this is a novel virus and we're learning more about it all the time. But I guess from day dot, we've been trying to use as much evidence as we can. We've been building that evidence, and we have tried to be as cautious as possible in that space of not knowing everything.
Of course, the precautionary principle is not a matter of choice. In your work, it's a statutory requirement, is it not, under the South Australian Public Health Act?
Yes, so that's one of the principles of our Public Health Act, yes. And also the proportionate principle as well.
Is there one more P principle that's relevant here, the population focus principle?
Yes, so of course we've got individual people in our community, which when I have on my hat on as a paediatrician is my clear focus. But when you're working in public health, then you're looking at the whole of the population, and therefore what might be unjust for one person, i.e. requesting them to be in hotel quarantine, may be being done for the well-being of the whole population.
And that balance, as I read the population principle in section 10 of the South Australian Public Health Act, requires decisions and actions that are taken under the Act to be actions that are necessary to protect and improve the health of the community. And in taking those actions, the health of individuals should be considered. That's the balance that's struck, yes, from a public health point of view. Am I understanding, yes, that correctly?
Yes.
You mentioned a moment ago, Professor Spurrier, there were a couple of matters that you wanted to raise in relation to the evidence that's been given by Professor McLaws. Is now a convenient time for you to do that?
Yes, thank you. So I think this issue of asymptomatic people with no symptoms whatsoever is a very important one, but we don't know everything about it. And we don't know to what extent, as far as I'm aware, how much of a risk they are in terms of transmitting the infection. And this is important because if we, when we're testing people and we're trying to increase the rate of testing, it means that we would be needing to test a large number of people who do not have symptoms. And the implication of that is we could be doing a lot of wasteful testing. Now, of course, I've got this, you know, sort of population-wide perspective, and all of our resources are finite, and same with our testing resources. And if we continue to be testing asymptomatic people unnecessarily, what it does is reduce the turnaround time of our test results. So we saw this in Victoria, where when they had very high rates of testing, their turnaround time became longer and longer. And then we don't get the ones that we really need back quickly. So our focus has definitely changed as AHPPC. We were very interested in doing quite a bit of asymptomatic testing, and in fact we have a surveillance plan here in South Australia which did include testing healthcare workers and aged care workers in a surveillance framework, i.e. when they didn't have symptoms, as Professor McClaws has suggested. However, we are really now wanting to focus on people with symptoms. And in fact, when you do speak to people that might have been considered asymptomatic, they often do have some very mild symptoms, albeit even if it's just a headache. So I think that's worth making the point. The second thing was being asked about a definition of shedding. One of the ways we use that term from a diagnostic point of view is that we do know that people shed the virus for quite long periods of time, and we've had patients here in South Australia who we can test them and they will still have a positive PCR result weeks and weeks, 6-8 weeks after the initial infection. That doesn't mean they're infectious to other people. We know there's some good evidence from China that the virus probably stops being viable, which means it is alive, about day 7 or 8. So whilst we can get a positive test result from somebody way out from their time that they had their initial symptoms, it doesn't necessarily mean they're infectious. So again, the interpretation of a PCR test is very, very important. And you did ask about false positives and false negatives. Yes. When we have large amount of testing in a community, and in our state we have had very few cases. So again, it's very, very dependent on the number of cases that you have. Any positive in South Australia has probably a higher likelihood of being a false positive than a real positive, just on a statistical basis. And the other thing that it might be worth the Commission knowing is that when you take a PCR or a swab test, so you swab the back of the nose and throat, you're getting a small amount of the virus RNA, and that is amplified up, and then a genetic probe is used to test that. And so the number of times you have to cycle to increase that amplification gives an indication of how much virus is there. But it's not a yes or no from a laboratory point of view. There's some art and interpretation required. And we do know that some laboratories have a different way of interpreting it, which is why we do get some possible positives or likely positives that they then go and run on a different platform to ensure that it is correct. I can say from a South Australian perspective, SA Pathology has, I think, had 2 false positives, which, given the number that they've done is a very, very small number. So I think we should be feeling very reassured that PCR testing for COVID in Australia has a very low rate of false positives and is a very sensitive and specific test.
Thank you. That's very helpful. Professor Spurrier, are you in any position to make an observation about the numbers of false negatives from the data in South Australia?
Well, to be able to call a false negative, you then need to have had some evidence that that person is indeed a case. And so we do have a process if we feel very committed to the fact that that person has the sorts of symptoms that would be COVID, and we don't have any other explanation, we will re-swab people. And I'm aware of one instance in South Australia where that did happen to somebody fairly recently, where they were negative, they had symptoms, and then a couple of days later we swabbed them and they were positive. What I can't tell you, because I didn't have enough sample left, is whether they actually had 2 respiratory viruses. And in fact, the earlier symptoms were simply adenovirus or, rhinovirus or RSV or one of the other viruses that we have, because that would have been the other explanation for that. But I think if we had a large number of false negatives, we probably wouldn't be doing so well in Australia as we currently are.
Yes. Professor Storia, could I ask you about 2 matters that are raised in the very helpful submission that South Australia Health have provided to this Royal Commission? It's found at tab 27 of the General Tender Bundle. I wonder if you have a copy of it in front of you. I should have asked you that.
Yes.
All right, pleased to hear that. Could I please, if that could please be brought up, it's AWF 600.01744.0001. If I could ask you, Professor Spurrier, to turn your attention to page 8. I'm not ignoring the first 7 pages, but we have limitations of time, and I assure you it's all very helpful. Towards the bottom of that page, or from about the middle, you talk about the potential for, the need rather for there to be a clear governance framework when there are so many different agencies involved, both Commonwealth and state, and aged care providers. And unless there's a clear set of ground rules as to who's responsible for what, there's the obvious potential for confusion, and therefore that will detract from the ultimate response to an outbreak, particularly in an aged care facility. Immediately above a series of dot points at the bottom of the page, do you see that about 3/4 of the way down the page? You say, or the submission says rather, a clear governance framework would have been beneficial, one that defined the roles and functions of each body impacting on the aged care sector and established communication points where information, feedback and directions are exchanged. And you identify various matters covered there. The evidence before the Royal Commission will be that after the second of the outbreaks in New South Wales, that is the second of the major outbreaks, the one at Newmarch House in April, that a protocol was agreed between the New South Wales and Commonwealth governments, which governed the matters that you're there describing in relation to future outbreaks, and that protocol is part of the evidence here. Is there such a protocol in place in South Australia?
So we certainly have a COVID outbreak plan for aged care and disability care. And it's very important that you have a plan that's in place way before you need it. And it is agreed by everybody. And it's also important that you have opportunity to exercise that plan, either on desktop, but preferably by some mock scenarios as well. And I think it's important that the commissioners understand that we have not had an outbreak in a nursing home in South Australia at all. We've had one instance in our first wave of COVID-19 where an allied health worker who had travelled overseas tested positive, but there was no transmission from that person to anybody in the aged care facility, so it was not defined as a cluster or an outbreak. So it is, so we certainly do have a plan. But I think the other thing that has been absolutely key for us in South Australia is that we've been meeting with the industry leads over a long period of time, so have very strong relationships with them. These are, and I'm not sure if it's listed in here, but they are Leading Aged Care Australia, Aged Care Industry Association, Aged Care SA and Multicultural Aged Care. And our lead in aged care meets with these people on a weekly basis. This has meant that we have had a much, a really good understanding of the various pressures on that industry and their ability to be able to deal with a positive case in their setting.
Thank you. I'm not sure if I expressed my question as clearly as I could have. I certainly understand there's a COVID-19 response plan in South Australia. What I was asking was a narrower question than that, whether there is a protocol or some similar document that governs the relationship, for example, between the Commonwealth Department of Health and your area where you work in relation to a response to an outbreak in a residential aged care facility. Are you satisfied that those roles have been appropriately designated for the purposes of the South Australian response?
No, I can't say I am sure whether or not we have a framework, but I'd like to take that on notice, please.
Sure, if you could do that. If I can ask you to turn your attention to page 11 of the submission, please. And you'll see halfway down the page, there's a heading RACF COVID-19 Pandemic Support Initiatives. Point 2 there is refers to the management of COVID-19 in residential aged care facilities process, which was released on the 5th of June 2020 and developed in collaboration with the aged care sector. And then there's a discussion in 3 of the contents of that policy. And if I could read that out, it says, the policy outlines that all residents testing positive to COVID-19 would be transferred to a public hospital to reduce the risk of transmission to other residents, and that the South Australian Health Rapid Response Plan will be triggered if there is one COVID-19 case in a residential aged care facility or other congregated living environment. The policy will also consider issues uniquely associated with regional and remote RACF and ensure that it is relevant to and feasible for those services. Now, in the media, Professor Spurrier, there have been comments made by some of the representatives of the peak aged care bodies that that's a policy they would like to see applied in other jurisdictions. You may be familiar with that sort of commentary. I take the point you made earlier that you haven't had an outbreak in a residential aged care facility, so it's a fair comment, isn't it, that this policy has not actually been tested at any time in South Australia?
Yes.
But I wonder if you can assist the commissioners with understanding the thinking behind it, and is it predicated on a view about the limited ability of a residential aged care facility to apply the sort of infection control requirements that Professor McLaws was talking about? Is that what underlies the policy here, or is it something else?
There's a number of things, and that's one of them. So in South Australia, again, it is very dependent on the geography, but also the way one's health care system set up, and each state is slightly different. But very early on, we decided in South Australia we would take the advice of the WHO, and this was information that was provided to us after the WHO had done an investigation into China and they're dealing with the pandemic. And one of the learnings from this was that it is best to treat all your COVID-19 patients in the one hospital or in a limited number of hospitals. And so, of course, we're a much smaller state, so and we have a networked health service. So we very early on decided that the Royal Adelaide would be our COVID-19 hospital. Obviously, children would be at the Women's and Children's, and if we had pregnant women, that would be at Flinders Medical Centre. And the reason for that is what they'd learned in China was that, of course, you can get transmission between patients and to staff, and it's much better to have everything in the one spot where you have got focused expertise. And fortunately, we have the new Royal Adelaide, which is very well set up with individual rooms, negative pressure rooms and the like, and also an extensive intensive care. So if we see it in that context, I think it's useful. So then getting back to the question of having a positive patient in an aged care facility, yes, definitely. We had heard very loudly from the sector. I just need to make people aware, as a paediatrician, I obviously haven't worked with elderly patients from a clinical perspective. I haven't worked in an aged care facility, but my understanding is that the personal care assistants do not have tertiary qualifications and are often fairly untrained. It's often a casualised workforce, and often and sometimes, I should say, of people from non-English speaking backgrounds as well, and that don't necessarily have the training in the use of PPE. One of the things when you use a personal protective equipment that is always helpful is if you actually understand microbiology and you understand how infections are passed from people one to another. So if you don't have that basic understanding, even if you've been trained in how to wear a mask and how to put on gloves and such like, you're not always going to be doing that at the same level as people that have that full understanding of infectious diseases. So we felt that it was, if we had a resident in an aged care facility, that it would be very quickly that would spread to not only other residents, but also other workers in that facility. We're also mindful that aged care facilities are all quite different. There are some that do have, might have ways of being able to isolate a resident or a number of residents in a separate part of the facility, but we couldn't be making that assumption about all aged care services. So we couldn't be confident that the actual infrastructure or the environment was set up in that way. One of the other considerations for us, and one of my teams looks at health licensing. So since 2018 in South Australia, we as SA Health have provided licensing of health services. So we have got quite a strong infection control team, and they take an enormous amount of effort when they go to a new hospital or a new day surgery to make sure that the doors are in the right place and that the sinks are in the right place and such like. There's actually quite a lot to providing a environment which has extremely good infection control. And we knew that that's not the case in many of the aged care facilities. So this is the reason why we put in our guidelines that we would transfer any positive resident straight into the Royal Adelaide Hospital. Now, of course, that has some difficulties associated with it. Obviously, we need to make sure our transfer is going to happen quickly and slickly. And I happened to be in Mount Gambier last week and was talking to the health services, and also I had a round table with the aged care facilities down there. And what we do want is to have the person transferred as quickly as possible, and we'll be using the Royal Flying Doctor Service to do that, rather than have the person go into the hospital and then have a secondary transfer out. So I guess what we have tried to do with our plan is to work through all of the different scenarios to make sure that it would be feasible. Now, this doesn't necessarily and may not necessarily work in other jurisdictions, but because of the way we have a networked health system, we felt that this was the safest option.
Just a follow-up question, if I could, about that. It probably goes without saying that the ability to transfer a COVID-positive resident from an aged care facility to hospital is going to necessarily depend on the availability of beds at any given moment.
Yes. So we have again, very detailed plan of how we will take existing patients from the Royal Adelaide and decant that and a ramp down. And in fact, we had a practice of that when we closed our old Royal Adelaide and moved everybody to our new Royal Adelaide. So fortunately, we have a lot of learning from that experience. And so again, as part of our plan is that we will have room for the aged care residents when and if we need it.
Thank you. Just one last question on this topic for you, Professor Spurrier, and I'll come back to you, Professor McLaws. If tab 10A in the general tender bundle could please be brought up. And I'm not sure if you've got this in front of you, but this is a South Australian Health document entitled Management of COVID-19 in Residential Aged Care Facilities. You'd be familiar with this, Professor Spurrier?
Yes.
If you can focus your attention about a third of the way down that page, there's a paragraph that commences, if a resident tests positive to COVID-19, they'll be transferred immediately to hospital by ambulance. This is a public health response to ensure the resident has access to appropriate medical care if needed and to protect other residents and staff from exposure. I can just pause there. That's consistent with the evidence you've just been giving based on the submission that I was asking you about.
Yes.
The document then goes on, the resident's family substitute decision maker will be notified immediately. If a resident has an advanced care directive and they are unable to make their own decisions, their healthcare wishes will be respected in the hospital setting, end quote. Can I just ask you about the thinking underlying that? And what I mean by that is if the advanced care directive, for example, is that they don't want to be hospitalised, how can it be respected in a hospital setting?
Yes, that's a very good question. So what we're seeing here is this requirement from a public health perspective and taking into account the precautionary and the proportionate and the population health requirements in public health to override the requests of an individual patient. However, we would absolutely want to support the Advanced Care Directive, and this is why we have this statement. So one shouldn't make the assumption that being taken to hospital is about being given high-level tertiary health care, clinical care. It's actually about putting the person who is infectious into a safe environment so that they're not able to pass that infection on to other people. So it's exactly the same reason when we have somebody with a mild clinical infection of COVID in the community, say a young person in their 30s tests positive, and we say, well, you need to remain in your home in isolation for the required number of days, and we will enforce that. We give them an order, and the police will check on them to ensure that that's complied with. And they're checked. They have a hospital at home system wrapped around them so that they get their healthcare in the home setting. Now, that person's rights as a citizen of South Australia have obviously been overridden by the requirements in this pandemic to not pass on the disease. So normally we don't obviously enforce people into home detention, but we are now to avoid the spread of disease. So this is the same here. We are requiring that this person go to the safest place in terms of not spreading the disease any further to other vulnerable residents in that home.
And finally, Professor Spurrier, is that a practical example of the population-focused principle that we discussed earlier?
Yes, exactly. And I suppose it's also worth noting is our hospitals are very, very familiar with palliative care and the use of advanced care directives. And there should be no misunderstanding that being taken to hospital is about being provided with a higher level of care than what that person would.
Thank you. Finally, if I can come back to you, Professor McLaws, in paragraph 9 of your précis of evidence, you make the observation about the necessity for hospital transfers of COVID positive residents in aged care facilities. Is the underlying principle there essentially as Professor Spurrier has described? Is there anything you'd like to add to that evidence?
Yes, I concur with that. I'd just like to correct a misunderstanding. My initial description of the people shedding was those in residential aged care facilities. The positive and negative and asymptomatics were all associated with aged care. I'm not suggesting that we test asymptomatics in the community. It was all aged care and their staff. But yes, one of the problems is that aged care is basically a shared home the built environments are all different, from cottage to a larger complex, but none of them are set up with best practice for infection prevention and control.
It's said by some in support of the proposition that an outbreak can be appropriately dealt with in a residential aged care facility, that facility that, for example, has individual rooms with individual ensuite bathrooms and other such features. There might be the ability to internally cohort, that is to divide groups positive from negative. What do you say? Do you accept that that there may well be residential aged care facilities where it is easier to address a COVID-19 outbreak, and therefore the need for hospitalisation might correspondingly be reduced? Perhaps if I could ask you, Professor McLaws.
I think that would be very difficult. It sounds easy when you put it to me, but in fact it's very difficult. In a hospital with best practice, what you would find is that staff do not share their care between positive and negative patients. That's best practice. Best practice is you do not have negatives anywhere near positives. So if you could put them totally in a different building, that might be okay. But of course, often these rooms or units actually belong or are being given to the residents for the extent of their life. So to move them out so that you could cohort positive people into rooms that have all single bathrooms might be okay, but it may cause a lot of distress and disharmony. But one of the other problems is that you would have to set up, as they did during SARS in 2002, an area where you could don and doff your gear in separate areas so that you're not going into the corridors that are potentially now dirty areas. What you need to do, best practice, is put on your personal protective equipment, go into the room, and then exit in a different manner, or take your personal protective equipment off before you exit, but you have to have your mask still on because you don't have enough correct airflow change to ensure that you're not going to breathe in particles as you leave the room. Then leave. Where is the hand basin for immediate hand care? Or I guess you could set up an alcohol-based hand rub and a separate area that you walk to. But it's just not best practice. Best practice is to potentially have a separate entry and exit, but they don't always have that in hospitals anyway. But certainly in infectious diseases ward, they've set it up so that you're not potentially contaminating your gear as you're leaving with your dirty gear on. And you'd have to have staff that have been trained and purposefully trained in infection control of a serious respiratory infection such as this.
Thank you, Professor McLaws. I'll just ask you if you can talk as close to the microphone as you're able to, because it's just a little bit hard to hear at our end. And I'm told by the technical support people that the problem's at your end rather than ours. Just one final matter, Professor McLaws, concerning the community transmission increases that we saw in Victoria starting in the middle of June. So I'd ask you to accept that the data is that from the 16th of June, there were 20 new cases in Victoria, and that gradually increased so that by the 1st of July, there were 73, and by the 8th of July, there were 149. We know that masks were made compulsory for aged care workers on the 13th of July, by which time the number was 249. The question's a simple one. Should masks have been made compulsory earlier, in your view?
Absolutely. Masks were universally required in Victoria in the beginning of July. So I'm not sure why the residential aged care facilities were considered any different to hospitals. Given what we know around the world and what we had known about Newmarch House and anywhere else. So it seems a little unusual that that occurred. And I was looking at the data as the numbers were increasing anyway. And in fact, the universal mask use for healthcare workers at the beginning of July was a bit late as well, because the numbers in aged care and health providers were starting to ramp up by early July. Before then, June 25, Newmarch had happened, and in May, some numbers were starting to occur in residential aged care facilities already in Victoria. So one of the problems, as an outbreak or an epidemiologist, it's best to act preemptively rather than reactionary. And often that means putting in place infection precautions, such as you've mentioned previously on the precautionary principle. That's what you do in outbreak investigation, and you respond rapidly. 1 or 2 cases, as they started to increase in June, should have been an alert that this is potentially a problem. Now, there could have been in, I'm only going on the public data that I could look at from Victoria, but nevertheless, whether they were in staff or residents, that heralds to me a potential problem, and a mask is a very cheap and effective method. We now, of course, require healthcare workers in hospitals to wear face shields or goggles to protect their eyes as well.
Finally, Professor Spurrier, if I could just bring you in on this point, because when the Minister for Health, Mr Hunt, announced on the 13th of July that aged care workers in Victoria would be required to wear masks, he said it was on the basis of advice from the Australian Health, I've forgotten the name, the Health Protection Principal Committee, of which you're a member. Are you able to assist the commissioners in understanding what was the trigger that triggered that advice by the committee? Why was it made when it was made rather than earlier, as Professor McLaws suggests perhaps it should have been?
Actually, I'm afraid I can't answer that question, because the AHPPC is a subcommittee of National Cabinet, and I can't provide that information outside without seeking prior approval. I'm sorry.
That's all right. I know you're not here to speak on behalf of the committee. It's the case, isn't it, that there was no published advice by AHPPC on that issue at that time? Is that right?
Yes. I just if I could make another point on the use of masks.
Yes, please.
So we're obviously in a different situation in South Australia, but again, looking at what we have learned already in Australia. So we will be looking at making masks mandatory in aged care facilities for times when staff are doing close care, so 1.5, within that 1.5 to 2 metre range, because of the vulnerability of the residents. Now, that is definitely very precautionary, given that we don't have any, or at least any major problems with the disease in our state. But some of the reasons behind that, and we have spent some time talking to the industry, is actually getting people used to wearing the masks and getting them used to using PPE, and also getting the residents used to seeing somebody wearing a mask as well, rather than it happening all of a sudden. So this is something that our police commissioner, who's our state commander, is considering, and that may well be put into a direction. It isn't at the moment.
Thank you very much, Professor Spurrier. Thank you, Professor McLaws. Commissioner Briggs, do you have any questions for either of the panel members?
Thank you, Council. Yes, I do. The first is quite a straightforward one to Professor McLaws, and that is, in the case of elderly residents who are confused with dementia or other conditions, can Can the COVID test be effective using fecal matter?
Not every COVID patient will excrete a virus in their fecal material. Certainly, I've been doing work in wastewater sampling for pathogens, and I know that some of my colleagues are testing it for COVID. One of the problems is that not every person excretes it, and when they do excrete it, it doesn't mean that they're either infectious. It could mean they were infectious. So it's just the RNA. So it doesn't tell you at what phase of the infection they're at.
Thank you. My second question is specific, well, firstly to Professor Spurrier, but I might ask the same question of you, Professor McLaws. Professor Spurrier, if you were in another state, say Victoria, would you be recommending compulsory hospital transfers for any people in aged care diagnosed with COVID-19?
I can't answer that question because I'm not familiar with the healthcare system of that state. Now, it is very dependent on knowing how your hospitals are set up and how they're networked and what the governance is for that system. So I really find that's an impossible question for me to answer.
Thank you. What about you, Professor McLaws? We can't hear you at all, I'm afraid.
Sorry. Let me just check my...
You're better now. We can hear you then.
Okay. There. Is that better? Sorry.
Yes, thank you.
Okay, from a WHO perspective, we make it very clear that it's very difficult to keep negative residents safe. So regardless of each state's ability to take residents into hospitals, they need to be decanted, they need to be removed and put somewhere else that's safe, looked after by highly trained staff. Given that both negative and positive residents have equity, they do have a right for good health and care, which basically means that negative residents have a right to remain negative. So we do know from New South Wales experience, from the United Kingdom, Ireland, Hungary, the US, Germany, and I could go on, that the evidence is that the attack rate, once you get a resident that is positive in a residential aged care facility, it's very difficult to keep the rest safe. And the attack rate can go from anywhere between very negligible to up to 100%. So it's very difficult. So I would be suggesting that the positive residents need to be put somewhere away from the main building, either in hospitals, in a purpose-built facility that has proper or can have proper airflow change. During SARS 2003, they didn't know if they were dealing with aerosolized or droplet particles, but they made these SARS designated hospital negative air pressure rooms 100% in 72 hours. They begged and borrowed HEPA filters, and they put in proper air conditioning so that they could provide negative air pressure. Now, I'm not suggesting that this is an aerosol transmitted infection, but you never know if you're going to have to do an aerosol generating procedure. Secondly, we have at WHO, I can't tell you, I've signed 5 confidentiality agreements, but I can tell you that at the moment we are seriously talking about the problems
regardless of what size the particle is, of a very low airflow and how it does encourage transmission, regardless of whether it's through droplet or aerosol particles. So my stance is you need to either put them in what's called ICU pods, but one of the problems is you can't even hire those to put them on some of the campuses because they are, some of these aged care facilities are cottages or homes, but there are such things that you can hire to keep people in a very safe place and keep healthcare workers safe while they're caring for them. Other than that, a hospital is the best place for them. Thank you.
Thank you.
Just one
That's
matter
it from
briefly.
me.
Thank you, Commissioner Briggs. Just one matter arising from that evidence that you just gave. You used the expression, Professor McClaw's attack rate. Is that the rate at which the virus spreads, essentially, is it?
Correct. Yes, it's sorry for that. It's the proportion of cases that occur within an aged care facility.
Understand.
So of all of those that are in an aged care facility, you may be able to prevent 99%, or you may get 100% of residents acquiring COVID.
Thank you. Commissioner Picconi, do you have any questions for the
Thank you,
witnesses?
Mr. Rosen. Professors, thank you both very much for your assistance in our inquiries. It's been exceptionally helpful and a very informative way to begin the process this morning. So thank you both very, very much indeed for the time you've made available and for the evidence that you've given us today. Thank you.
Thank you.
Thank you.
Mr. Rosen, we might have a briefer adjournment, perhaps 10 minutes,
yes.
And we'll resume it in 10 minutes.
Commissioner, it's Ms. Dakey from the State of South Australia. Please may I be excused from further attendance in this hearing block?
Yes, of course. Thank you.
Thank you.
Commissioner, I did have one other thing I could add, but I wasn't sure if I was going to be asked for an opportunity.
Oh, well, I think you should add it if you can.
Thank you. So this is another consideration for why it would be preferable to have a positive case in an aged care facility shifted. One of the things that we noticed in South Australia, and I think was noticed in other states, was that when we, in our initial directions across the nation to shut down and lock down nursing homes and restrict visitors, it meant that that of course there was not that other set of eyes in terms of the resident's family to see how things were going for that particular resident. And unfortunately, there was an overreach, which you may be aware of, so that some facilities shut down completely and their families were not able to visit. One of the things that I have noted, and I'm sure people are also aware of, that in Victoria, when they've now had the crisis with the with some of the aged care facilities, it's been very difficult for family to be able to see their loved one, and that's obviously extremely traumatic. One of the positives about having a positive COVID patient in a hospital setting, because of the more sophisticated use of PPE, it would allow, I believe, a better ability for the family to spend some quality time with their loved one. Thank you.
Yes, thank you. That was a very important addition. Thank you, and for that additional remark as well. And I formally need to excuse you from further attendance. So thank you, and you are excused.
Thank you very much.
We'll adjourn now for 10 minutes.
The Royal Commission is adjourned until 12:25 p.m. The Royal Commission is now in session.
Mr. Ralston.
Thank you, Commissioner. I call Ms. Merle Mitchell.
Ms. Mitchell, do you solemnly and sincerely declare and affirm that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say
I do. I do.
Ms. Mitchell, could you state your full name, please?
Merle Velma Mitchell.
And where do you live?
In Glen Waverley, in the Waverley Aged Care Facility.
Have you prepared a statement in this matter?
I have.
And have you got a copy of that in front of you now?
No, I don't actually, but it's in my head.
Okay, all right. For the record, Commissioners, the statement is document ID WIT 0107 0001 0001, and I tender that statement.
Is that not part of the bundle already?
No.
All right. That will be Exhibit 18-5.
Now, Ms. Mitchell, you gave evidence in May last year in which you described your experience of having lived in residential aged care since 2016.
That's correct, yes.
And the facility you live in is located in Glen Waverley in Melbourne?
That's correct, yes.
And how many people live with you there at that facility?
Oh, I think it's about 130 at the moment.
And has that facility had any positive COVID-19 cases amongst the residents that you're aware of?
No, we've been very lucky. We haven't
What about
had any.
And what about the staff?
And we haven't had any staff person with it either.
All right. And you, as you say in your statement, you're currently living in a state of lockdown. That's correct?
That's right. That's correct.
Tell us, what does the word lockdown mean for you and the other people that are living in your facility at the moment?
Well, it means that I'm in my own room. The only time I can go out of this room is when I've got a physio session, and that happens 4 times a week. Otherwise, from the time I wake up to the time I go to sleep, I'm sitting in my own room in my one chair.
Do you have a window?
No, I can look at a brick wall, but that's all. There's nothing else to look at.
Can you see a tree or a garden from where you are?
No, can't. Not the way the building is constructed. Yeah.
And how long have you been in lockdown?
Oh, we went down in month. Overall, it's in a couple of months. We've been in lockdown once for about 3 weeks, and then we had 2 weeks without being in lockdown, and then suddenly we were in lockdown again. So we've been in lockdown for quite a long time.
When did you last, well, I would draw that. Your daughter, she has helped you in the past with a lot of the things that you need to get done to live, correct?
Yes, yes, but she's not allowed to come anymore.
When did you last have some physical contact with her?
Oh, I was lucky enough to have a birthday a couple of weeks ago, and I saw her then, but that was only through an open window. It was two inches open, but that's the last time. And it was
she?
Yeah, sorry.
Was she outside in the cold? Was she?
She was indeed. I was in the warm place, but struggling with the sound, with the noise in the room behind me.
Now, are you able to have any video contact with your daughter? Speak to her that way?
Oh, yes, I can, but I'd rather use the phone, so I use the phone. Yeah.
Is that enough for you? Is it enough just to talk on the phone or on the computer?
No, I'm a people person. I like to see people in, as they are, not through the phone. Yeah.
What about the? Sorry, you go on.
But I understand why we're in this situation, and that we've got to put up with it until things change. Yeah.
So in your statement, you say that the lockdown originally happened in about February of this year.
Yeah, that's right. Yeah.
And how has the lockdown changed over time? Has it been relaxed in any way?
No, it's got worse. The first lockdown, my daughter was able to visit, and we used a glass screen between us. Prior to that, she was able to come once a week to help me with things that I needed help with. And then that progressed to just one visit with a glass wall between us, or a glass screen. And now we can't have any visitors at all.
Now, was there any talk about the lockdown coming to an end in May and early June when things were looking relatively good on the COVID front?
We probably hoped it was going to go away, but that was, yes. Nobody said it is going to go away. We just hoped that we would go back to where we were.
So how were you kept informed by the facility management about what was going on?
The general manager sends out a letter every Monday to let us know where things are at. And that's when he details who we can have as visitors and who we can't.
And you mentioned that there's a rule about what has to happen if you go outside to see a doctor.
That's
you recall
right.
that?
Yes, I have to go into isolation for 2 weeks. And in isolation means I go into a very small room without a window. This was my first experience. And I don't see anybody except the people who bring the food into me. So it really it's a real lockdown. Yeah.
How many people are you aware of that take that option when they have to go and see a doctor or get some treatment?
I think people are encouraged not to keep those appointments, and so they go without. Yeah, as I have done with 2 fairly essential appointments that I have, but I've decided better not to go.
Does your GP visit you in the facility?
Yeah, yes, he does. Yeah.
When the GP comes, does he or she do they wear a mask or personal protective equipment?
Last time I think he did. Yes, he wore a mask. Yeah.
And does the facility encourage you and the other residents to wear a mask?
No, all of the staff wear them, but not the residents. Yeah.
So the staff wear the full face mask, do they?
Yeah.
Or do they wear one of these surgical masks?
Yeah, it's a surgical mask that they use. Yeah.
And no one has suggested that the residents should wear the masks at this stage?
Not at this stage, no.
All right.
Unless they're going out. Unless they're going out and then they take a mask with them. Yeah.
Ordinarily, would you be going out to visit friends, even though you're living in the facility?
Yes, I'm a great user of the multi-purpose taxis where I can have my wheelchair. I can be wheeled in my wheelchair up into the taxi and taken to wherever I need to go. So I'm missing that very, very much. But I understand why.
Now, have you observed there to be more or less staff available to help you during this period?
It's about the same. I have sent a number of messages to say, because of the extra responsibilities that the staff now have, they really need to put at times, particularly in the mornings, at meal times and going to bed times, they need extra staff. But that has
Can you give us an example of the sort of extra responsibilities that you've seen the staff?
Well, because we all eat in our rooms, for example, they have to bring our meals to us and have to collect the tray after we have finished. And so if we're wanting a cup of tea, they have to bring a cup of tea around to us. There's much more responsibilities that they have.
You mentioned that the physio can come in and see you. Is that a regular appointment?
Yes, 4 times a week. But we have lost our masseurs. So no longer can I have the massage, which is very much part of my care plan. She's been told that she's not an allied health worker, and so she can't practice anymore.
Is the physio able to make up that gap that you're missing with the masseur?
Not really, no. No, it's a real gap now.
And what does that mean for you?
Oh, I guess it means that I just don't get the relaxation of my muscles that Kim was able to give me. So I try and do it for myself as much as I can. But I really think that they are a very essential part of anyone's care if they have mobility problems.
What about getting your hair done and other personal choice matters?
Well, hairdressers are not banned. They're not allowed to be here. And that caused enormous problems for lots of people where it was their only job that they had. Yeah.
When were you last able to get your hair cut, Mrs. Mitchell?
I reckon it's a couple of months ago now.
Yeah.
I was due to get it when we went into lockdown on the very day that they brought it in. So the timing was not good. Was it?
What's it like living in aged care in Melbourne as you see the numbers around you in the other facilities going up day by day? How does that affect you?
Oh, I think I've got to the stage of being accepting. You know I'm here till I die. So every morning when I wake up, I think, damn, I've woken up, but I'm here till I die, so I've got to make the best of it. And that's what I try to do. Which is not to say that I'm not being cared for, but I'm sure that if you really ask most people here, they would all say they would rather be dead rather than be living here, if they're honest, that is.
What have you seen of the effect on the people that live with you? How do you see them coping with the lockdown?
I think for those with dementia, it's been very difficult. I don't think they understand why the lockdown, why family are not coming with them, coming to see them. Many people here had family who came in every day, at least once a day. They helped with feeding people. They helped with all sorts of little things, just companionship, really. And that's all gone. And I think that's had a very, very bad effect on those people and their families.
What leads you to that conclusion? What do you see in their behaviours and the way they interact with one another?
I've had more experience over the last few days of one of the residents who starts off by coming in and saying, "You've got my coat." And I say, no, this is Merle's room. You're in a different room now. And so she goes off and she finds somebody to come with me. And the next thing I look up and they're sorting through my books to find her coat. And that's, look, I accept that. It's part of their dementia that's creating and their loneliness that the families are not here. And that's their, a natural reaction for them, really.
Last year, you were asked about the experience of moving into aged care. And I want to read back to you what you said. And I want to get your impression about whether things have changed, whether they've got better or whether they've got worse. This is what you said. You said it was terrible. There's a shock when you move into aged care. There's the shock of loss because what happens is it is so quick. There's not the recognition of loss because loss is not just death. Loss is loss of your way of life. How has what's going on in Melbourne now changed you since you've made that statement?
Well, I think I pretty much feel the same way. There's been a change in some of the training of staff, but if I still have staff say to me, when I say, I'd rather be dead, and I get growled at for saying that, you must not say that, you mustn't have negative thoughts. Well, they're my thoughts. And I own my thoughts. But I think for staff still, even though they're surrounded by death all the time, it's very difficult to actually acknowledge that people feel that way and they don't want you to be expressing that.
I have no further questions. Thank you, Commissioners.
Yes, thank you, Mr. Wilson. Commissioner Briggs, do you wish to ask anything?
No, I don't. Thank you.
Thank you. Ms. Mitchell, thank you for making yourself available. I know that you've given us a lot of time for 2 sets of hearings now, and you've given us a lot of time for this hearing with the written evidence that you've given us, and now this morning. It's very important for the whole nation to hear the evidence of people like you, and we're very, very grateful to you for having done that. I do thank you very, very much, and I hope that things will improve. Thank you. I think I now must formally excuse you from any further attendance so that you can't be dragged off to prison inadvertently. Thank you. Mr. Rosen.
Thank you, Commissioner. I call Ross Lowe and Melanie Dix.
I didn't even pick up on the last two, the extra things I said.
Mr. Lowe, do you swear by Almighty God that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say, I do.
I do.
Ms. Dix, do you swear by Almighty God that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say, I do.
I do.
Mr. Lowe, could you state your full name, please, for the record?
Ross Gregory Lowe.
And you are the Chief Executive Officer of, I'll get it right, Baptist Care New South Wales and ACT, is that right?
I am.
Thank you. Ms. Dix, your full name, please.
Melanie Dix.
And what's your current position, Ms. Dix?
My current position is the Residential Operations Manager of Southern Region for Baptist Care New South Wales ACT.
In that capacity, you were part of the expert panel review committee during the outbreak earlier this year at Dorothy Henderson Lodge, is that right?
I'll give you a bit more clarification. I was actually asked by Dorothy Henderson Lodge sits in the Sydney region for Baptist Care, So I was asked by Baptist Care to come in and support the operations during the outbreak management for Dorothy Henderson Lodge. So I came in support and was joint operations manager for the outbreak with the Sydney Region Operations Manager.
Thank you. And what's your background, Ms. Dix?
My background is as a registered nurse. So I've got 27 years experience in health and aged care. I have tertiary qualifications in nursing and health service management. And for those 30 years, I've worked in aged care and not-for-profit in strategic and operational roles.
And how long have you been working for Baptist Care?
Since January 2019, so about a year and a half.
All right. And Mr. Lowe, I neglected to ask you, but how long have you been CEO?
10 years.
And prior to that, did you hold another position within Baptist Care?
Yes, I'd worked for a previous 6 years and was in a business strategy role and then into a chief financial officer position.
And going back further still, if we can, any previous experience in aged care?
I was on the board for 4 years prior to joining Baptist Care in July of 2004.
Now, I'm sure the two of you don't need to be reminded that Dorothy Henderson Lodge was the first aged care home in Australia to face an outbreak of COVID-19. The outbreak commenced on the 3rd of March of this year and was declared over on the 7th of May. Is that right, Mr. Lowe?
It is indeed, yes.
And Baptist Care, ACT and New South Wales responded to the Commissioner's call for submissions about COVID-19 and its impact on the aged care sector. Again, that's right, isn't it, Mr. Lowe?
It is, and in fact, we had decided even prior to receiving the request from the Commission that we would make a submission under those circumstances.
And why was that?
Because we had hoped that we would be able to learn or leave lessons with the industry in general as to how to cope with an outbreak of COVID-19 within a facility.
In relation to that, the submission makes clear that in addition to providing the submission to this Royal Commission, you have taken other steps to disseminate lessons that your organisation learned. Can you briefly summarise those for the Commissioners?
Yes, I attended a forum in Canberra on Friday the 6th of March and spoke to a large number of the peaks down there, plus the government departments and quite a number of CEOs of larger organisations. That was obviously in very early days and our learnings were still coming. I then did a webinar with AXA and a further webinar with Laser and have spoken to a number of not-for-profit and for-profit company organisations to help them understand how to cope with an outbreak of COVID-19.
For the benefit of anyone following that's not familiar with the acronyms that we all know in aged care, AXA and Laser are both peak organisations in the
yes, they are indeed. Yes,
representative organisations. Yes. Thank you. Sorry, and I might have cut you off there. Were there any other things you've done that you'd like to relate to us by way of disseminating the experiences more broadly?
No, I think that's the main areas that I've been involved with, and obviously very involved in crafting the submission to the Commission.
Yes, I'll take you to some aspects of that in a moment. But in addition to that submission, Baptist Care Australia has also provided a submission to the Royal Commission, has it not?
It has indeed.
And are you able to, sorry, I withdraw that. Were you involved in the development of that submission as well?
To some degree I was, but obviously the Dorothy Henderson Lodge submission, which was running concurrently, took up a greater part of my time. The Baptist Care Australia is organisations of each of the organisations in each state and territory, and a lot of that input was predominantly done by Victoria, linked with our own company secretary out of New South Wales, but also from from Queensland and from Western Australia had significant input to it.
In terms of the size of the organisation, in your submission, which I'll ask to be brought up, it's at tab 14 of the Dorothy Henderson Lodge Tender Bundle, Exhibit 18.2. Do you have a copy of the ACT New South Wales submission in front of you, Mr. Lowe?
Yes, I do.
If you could turn your attention to page 2 of that submission, please, paragraph 2.1, you inform the Commission that Baptist Care is quite a large organisation with more than 160 facilities and programs through New South Wales and the ACT. Is that right?
That's correct. They're not all aged care. A number of those are in the community services areas.
Yes. Are you able now to indicate how many of them are residential aged care facilities of that 160?
It would be probably in the order of 40 or 50 would be aged care.
Thank you. This may be a difficult question to answer, and if so, I apologise, but there are also home care clients who are serviced by Baptist Care, is that right?
Yes, indeed. We have about 9,000 clients throughout New South Wales and the ACT in the home service area.
Right, thank you. Now, both the submissions, both the one from the New South Wales organisation and the one from the national organisation, have been very, very beneficial to the work of the Royal Commission, and on behalf of the Commissioners, I thank you for them. In the time available, I'm only going to be able to take you to a few of the key points that are made, but I don't want you to get the impression that the rest of it is not helpful, because it certainly is. We also have the benefit here of a report prepared by Professor Gilbert in relation to the outbreak at Dorothy Henderson Lodge, which contains very valuable information that we'll explore with her later today. So I would like to start by asking you about the topic of infection control and the lessons that emerged from your experience. This might be more a question for you, Ms. Dix, than for you, Mr. Lowe, but I'll perhaps, so if I could start with you, Ms. Dix, and draw your attention to paragraph 6.3.3 on page 10 of the submission. What the Commissioners are informed of there, Ms. Dix, is that very shortly after the first notification of the outbreak, you were notified of that by the Chief Health Officer, that a staff member at Dorothy Henderson Lodge had tested positive, and there was then an escalation through the North Sydney Local Health District and the Public Health Emergency Operations. Am I getting these terms right? And NSLHD is North Sydney Local Health District and PHEO is Public Health Emergency Operations. Is that right?
That's correct.
Right. And within 24 hours that occurred, and on the 4th of March, you had Infection Protection and Control specialists from the Clinical Excellence Commission and Dr. Branley on site. So dealing firstly with the Infection Protection Control specialists from the Clinical Excellence Commission, had you had any exposure to the Clinical Excellence Commission before the 3rd of March of this year?
No, we hadn't.
You didn't have an existing role?
Introduction to the group.
What about the local health district? Had you had some dealings with them?
So there's a couple of statements in relation to that. So this is not normally my region. So I had come as an extra support for Dorothy Henderson. What I can make as a statement is that in my own region and our organisational protocols are that we do work with the public health of the local health district. during outbreak management and with infection control. So we absolutely have that relationship. And so that is the first statement for that. And then they did escalate it to the Clinical Excellence Commission for us.
And if I'm understanding what's said in the submission, that process by which you had access to expertise from the Clinical Excellence Commission was initiated by them, by New South Wales Health, is that right?
That's correct, absolutely.
Can you tell the commissioners from your perspective, and I should just clarify, on what date did you become involved in the Dorothy Henderson response? Were you there from day one, Ms Dix?
No, I became involved 24 hours later in the evening of the 4th of March. So it commenced on the 3rd. So I was 24 hours before I came on site. And by that particular point, Public Health Emergency Operations and the Clinical Excellence Commission had commenced their involvement with supporting us through the outbreak.
All right. Can you just give us an overview of that role? How did that work on the ground, the work of the Clinical Excellence Commission staff?
So the Clinical Excellence Commission specialist came on site, and that was Kathy Dempsey, and she was absolutely working in conjunction with Public Health, who had also come out on site prior in the 24 hours, and Public Health from Northern Sydney Local Health District had come out as well. So with the collaboration of the information that she'd received, she looked and reviewed our infection control program. She identified the local elements of the aged care service as well. So the specific support for people with a dementia diagnosis was a key element of that assessment, and made an assessment and recommendations to infection control practices and procedures that we implemented.
And that involvement, was that just on the 4th of March, or was that an ongoing involvement in responding to the outbreak?
So they came on site initially and regularly to provide auditing for us, and was a regular contact and provided support and advice. Not always on site, sometimes through telephone.
All right. And you've said there that they were complemented in that role by Dr. Branley, who's an infectious diseases specialist. So he's obviously a physician, not an infection control specialist in the way that Ms Dempsey is. Are you able to explain how those two roles complemented each other from what you could see in the response to the outbreak? What was it that Dr. Branley brought that Ms Dempsey wasn't doing, and vice versa, if you'd like?
Dr. Branley brought information and knowledge around COVID-19. He had participated in outbreaks internationally prior to that point. So he had provided some information and suggestions in relation to the management on site, given his practical experience. So the Clinical Excellence Commission was able to provide the parameters. They were also dealing with New South Wales Health at that particular time, because Ryde Hospital had already commenced their outbreak as well. So the interaction between Dr. Branley and Kathy Dempsey and New South Wales Health, it was a learning environment. There was a lot of information that wasn't known about the virus at the time, and how the infection control procedures applied to it. So it was very collaborative to have that opportunity initially, because it was the first outbreak in aged care. Yes.
At 6.6.1 of the submission on page 15, if I could just ask the bottom of the page be brought up, the submission there makes the point that you had well-established infection control policies and processes in place that were consistent with your obligations as a provider. I'm going to try and unpack that a little bit if I can. Had those policies and practices been put in place to meet the previous infection control outcome of number 4.7 in the previous aged care standards? Is that the point you're making there? Does that make sense? You know, before 1 July 2019, we had a previous set of aged care quality standards. Are you familiar with that? I'm sure you are. The accreditation standards. One of them dealt expressly with infection control. 4.7.
I understand. So what I'm hearing from you is your question is, were the infection control procedures responsive to the previous standards and not the current ones? And the answer to that is no. We had infection control procedures in place that respond to the current standards.
Yes.
The challenge that, and what we were trying to represent in this submission, was that the crisis nature of the COVID-19 outbreak was unlike previous outbreaks that we had experienced. So
yes,
aged care organisations regularly have to manage influenza and gastroenteritis outbreaks. The presentation of COVID-19 and the immediate crisis, particularly in relation to the contact assessment and loss of staff, challenged our infection prevention and control management in a way that we hadn't seen prior.
I understand. Was it, I'm just trying to identify what the differences were to your previous outbreak experience. So there's the impact on the staffing. It's been said that one of the significant differences between an infection control response to COVID-19 on the one hand compared to influenza on the other is that with influenza, you've at least got a critical mass of staff that have been vaccinated in relation to influenza. Are you able to comment on that?
So on the differences?
Yes.
In relation, absolutely. So there were a number of differences, and the timings of Dorothy Henderson's outbreak is also important. We were the first community contact, transmission of the disease as well. So it was only within the previous week that the first cases had been identified in Australia. So we had commenced an outbreak management of a virus which nobody knew all of the answers in relation to. So, and it was not usual for us to lose a high contingent of our staff to contact tracing, because you wouldn't normally lose that many staff in an influenza outbreak or a gastro management for it. So that was one of the first significant differences. The concern and the distress of the community was the second element that we were dealing with at that time. It was an unknown outbreak, and how the management of it, and concerns around how health services and health services may be able to support the community, particularly community that may need to access acute care services. So that was a consideration in the conversation as well. And what subsequently became an issue was the ability to access resources such as personal protective equipment as well, which we normally import internationally for some of those elements. So supply of those. None of those things had been a challenge in previous outbreak managements that I've been involved in.
I understand. Can I bring you in there, Mr. Lowe, in relation to the impact on the staffing question? Was one of the challenges that you faced with Dorothy Henderson the managing the fear of the staff? Can you tell the commissioners a bit about that? How did that manifest itself, and what did you do?
Yes, a lot of the staff had an immediate concern, in a sense, about their own well-being, and particularly with regards to those that then would go home to their family, and would they be transferring the virus out to their homes. So one of the things that we did was to create a video with Dr. James Branley and Kathy Dempsey to help us or help people begin to understand how to work with the virus, and particularly to use their hands, as he would say, as the vector, and the sense was up through the face. So as long as you keep your hands very clean and clear and continue to wash your hands regularly, then the spread of the virus is very low in relation. That had an enormous impact on our other staff as well, because other facilities were also being concerned about, would they pick up a virus in a community sense and bring it into that individual facility. So that way of looking at the video right across our organisation was very helpful, as well as being obviously very helpful for Dorothy Henderson Lodge.
There was no Commonwealth-funded surge workforce available to you, was there?
No, not at all. In fact, I'm sure from us, the development of the surge workforce became a priority and certainly a criteria for any further outbreaks.
How were you, sorry, I'll withdraw that. Were you able to draw on staff from other facilities as a relatively large-scale aged care provider?
Yes, I put a plea out to our staff, and we had quite a number volunteer to come across. We were also working with New South Wales Health, and they were able to give us a number of carers and registered nurses. And we, in a sense, borrowed people from all over the place once we had lost our staff to create that gap until we were able to then work in with Healthcare Australia as a provider of the resources going forward.
At paragraph 6.4.5 of the submission on page 13, you detail or list a number of strategies with Healthcare Australia to attract agency and other Baptist care staff, and they involved increasing pay rates, aligning them to acute sector pay rates, and other adjustments to working conditions. Simple question, did those strategies work? How did you find that?
They did work, and I think it was appropriate that we did that because it just gave us that opportunity not to take away that question. I think quite a number of them would have said that they were happy to come. That just made it all that more simple and easier for them to make that decision as well.
As I'm sure you're aware, Mr. Lowe and Ms. Dix, the aged care workforce is a great interest to the commissioners in their work even beyond COVID-19. Are there lessons from that experience about how we can perhaps attract and retain more workers in the aged care workforce, and particularly those with clinical skills?
I think one of the things we have done since is to gather a list of people that would be able to come to a particular facility if an outbreak took place, so that we would not have to send the plea out. We would have the outbreak and we would be able to immediately look at that list, approach those people that work for us currently, and say to them that they are now required to be at a certain facility, and they would be able to move across very quickly to take up the roles that we would designate for them. So that's been one of the learnings that we've been put into place, in a sense, as a reserve workforce to be able to go forward.
Ms. Dix, is there anything you'd like to add on that topic of workforce?
I think the one thing to add to that is these outbreaks have highlighted the need to understand what aged care services do provide as well. And the way that interacts with the health services, and the important interaction that both have a component within the health spectrum as well for that. And at the moment, the respect for the health worker as well for the magnitude of the roles they're undertaking is important to attract in attracting people to the industry.
I'll come back to that, but I think I'm about to go on to a new topic. Commissioner Bacconi, might be an appropriate time to break for lunch.
Yes, well, this session is due to go on after lunch in any event, so we'll resume at 2 o'clock.
The Royal Commission is adjourned until 2 p.m. session.
Yes, Mr. Rosen.
Thank you, Commissioner. Mr. Lowe and Ms. Dix, you can hear me all right, I hope?
We can.
Indeed.
Excellent, thank you. We got to a point before lunch where I'd been asking you some questions about the impact of the response to the outbreak on staffing. And I want to change topics now and ask you about another matter raised in the submission at 6.9, which is on page 21. If I could please ask you to turn to that. The heading there is access to acute healthcare, hospital, including pathology and ambulance services. You make the observation, which many witnesses are making in this hearing at 6.9.1, that interagency dependencies are crucial to aged care and became even more crucial when managing the outbreak. And you say that you had a good experience due to the close working relationship between government stakeholder during this time, but there were some challenges. Can I just ask you a little bit about the importance of having relationships in place in advance of an event like the outbreak at COVID? And maybe this is one for you, Ms. Dix, perhaps not so much in relation to Dorothy Henderson, but in relation to your day job, if I can call it that. Can you explain a little bit to the commissioners about the nature of the relationship? You touched on this earlier about the local health district. How important is that so that you've got that groundwork so that you're not all meeting at the time of the outbreak? Can you deal with that, please?
Absolutely. Prior to an outbreak, there has to be a good working relationship between the local health districts and aged care providers because of the interchange between our service provision and what they provide. And that so many of the services that aged care people in facilities use sit in the health services. So there really needs to be an understanding. We can't do it without the health service, and nor can the health service do it without aged care services. So an understanding of how operations and the resources occur and how that interaction will happen is paramount to this process.
I meant to ask you, I'm sorry. No, I meant to ask you, you go, please.
Sorry. And it also includes plans and agreement of roles and responsibilities, which is important to be predetermined prior, but at the commencement of an outbreak, all of those issues need to be assessed. So to understand that the right people are making decisions and understand what's happening for the operations. Because the other component to this is each aged care service, just as each health district, is different. So the partnerships need to understand the local specifics of each service and how they'll interact.
I meant to ask you earlier, Ms. Dix, and I neglected to in the context of infection control expertise. I meant to ask you to reflect on any differences there might have been between the experience of Dorothy Henderson and the later experience you had at Newmarch House when you went over there as part of the in-reach management team that came from Baptist Care. It was a different experience there, wasn't it, with infection control expertise? You didn't have that immediate on-the-ground expertise. Can you discuss the differences from the point of view of responses to the outbreak between Dorothy Henderson and Newmarch House in that respect?
Absolutely. In relation to Dorothy Henderson, we did have infection control expertise that had come from initially the local health district and then from the Clinical Excellence Commission immediately on outbreak. And what was paramount for us was those relationships and the collaborative approach that we undertook, that we all understood what we were trying to achieve and how we were going to achieve it, and understanding the operations. And because I was inherently involved in the evolution of that in Dorothy Henderson, I can say that was a collaborative relationship that we worked very hard at and understood. When I went into Newmarch, it had been running since the 11th of April and I went on the 24th. And at that point, there had been infection control support there, but I identified that there was need for more infection control expertise, and that's where I contacted Kathy Dempsey. Part of it was we had a pre-existing relationship and being time critical, being able to put in simple systems or enhance the systems that they had.
Is it the case, Ms. Dix, that's very helpful, is it the case that as with any emergency response situation, you need to, as a responder, you need to know what you need, and you knew what was necessary because you'd had the experience just the month before at Dorothy Henderson. Not every provider is aware of the gaps, if you like, in their response arrangements. I'm wondering if you can reflect on what the lessons are from that experience from a sector-wide perspective. In other words, what arrangements do you think we could have in place now to ensure that it doesn't take a situation like that for a provider to realise they need someone like Kathy Dempsey? What do you think would be useful to have in place as part of preparations now?
I think there's two components to preparations, and there's one action at the commencement of a crisis. So the two components, as we've touched on before, is understanding the health services and also understanding the aged care services. Each aged care service has a specific profile with a response to clients with different components of needs. For example, a resident that's focused on supporting people with a dementia diagnosis relative to other care needs. And that's important for the health service to understand. There's also an understanding of how the community health providers that support an aged care service also interact with health and aged care. So that understanding of how the jigsaw puzzle of support for an older person happens when they're in an aged care service. The second is the development of plans and the interaction and those clarity of responsibilities of who will be involved at the time that an outbreak commences, and ensuring that the right people with the right delegations are involved in that planning process and agreeing on those plans. And then the third thing that I would say is that when we get to the point of a crisis, and COVID-19 is a crisis in an aged care facility, that those outbreak plans and emergency plans are rechecked at the time to determine the capacity and the capability to actually implement the outbreak plans. So some of the challenge that we had was in relation to the workforce, the understanding of contact tracing and putting staff into self-isolation challenged the resources of staff for that outbreak plan, just as the access to PPE challenged the outbreak plan as well. So there are three components: understanding, planning of how it's going to happen, but at the time of the critical event, assessing the capacity and the capability to continue with that outbreak plan.
Understand that. Just focusing for the moment on this quite narrow question of bringing in that sort of Kathy Dempsey type high-level infection control expertise. Very few aged care providers are going to have someone like that on a full-time basis. It's probably unrealistic to expect that. But the expertise is out there. My question for you is, I'll be more specific. Do you think it might be workable for, say, the Commonwealth Department of Health, in collaboration with the states, to identify the people with that expertise within the state health departments, the Clinical Excellence Commission type organisations, and then disseminate out those names, perhaps on a regional basis? So if you're in the western suburbs in Melbourne, there's 3 people that we reckon have got the sort of expertise you need. Here's where they are, here's their phone numbers, and get in touch with them, invite them over in advance of a problem so they can familiarise themselves with your residential aged care facility, and then they'll be on call for you day one. Do you think something like that might be useful for the sector as a whole?
Absolutely. Some sort of documentation and communication of a panel of experts, of infection control practitioners that could be accessed to participate in development of emergency plans, and then also in the participation of an outbreak, because what you need from that specialist is somebody who will oversee the infection control plan as it commences in the outbreak management documents and planning, and then monitoring the implementation of the plan itself. So a panel is a good solution, given that there are so many organisations that may be small or regional. access to specialist services are limited.
Yeah. Mr. Lowe, do you have anything to add on that issue? Do you see any problems with that sort of approach?
I think that'd be an excellent approach, and certainly you saw the benefits, or you've read the benefits of having them available to come into Dorothy Henderson Lodge so quickly.
Yes. Can I come back to the issue at 6.9.3 in your submission about access to hospital? In the Baptist Care Australia submission, the one that the national organisation has provided, they refer to this question as a contentious one, and I want to ask you a little bit about that in a moment. But for the moment, if we can just establish the progression of events at Dorothy Henderson, as you explained it at 6.9.3, it seems there were two phases to this question. Initially, there was a default hospitalisation of anyone who was tested positive, and then that changed through the course of the response to the outbreak. What changed? Was it a change of approach internally, or was there a change of approach that was externally that had external effect, as in the New South Wales Department or the hospitals? Can you help us, Ms. Dix, with that?
Absolutely. So initially, and again through collaboration and working with the local health districts, there was an agreement that those that had been identified as COVID positive, and for us, even though some of them had mild symptoms, they all had symptoms during the initial phase. So there was an agreement that they would all go to hospital. During the second week, New South Wales Health and the local health district then started to talk about appropriate transfer of residents who may need more clinical support that was able to provide at the aged care facility. But what that provided us with the opportunity was to actually stabilise our outbreak plan and ensure our resources were working. So aged care services are able to provide clinical support to older people and palliation. Our challenge was initially in relation to staff, having enough staff on site. So that change in the phase for us was almost directly in relation to us having enough resources to stabilise the service. And externally, what was happening in the community at the time was that this was on the escalation of the pandemic in Australia. There was concerns about health services being able to have the capacity to provide acute services to the community. So we were at the beginning of this process where the community was very concerned, and there was a level of hysteria and fear in relation to it.
Ms. Dix, I might just ask you if you could please to move that bottle of sanitizer a little bit away from the microphone in front of you. Oh, yep. Thanks. Thank you. Sorry, back to what you were just saying, and I want to make sure I understand this. Are you saying that that in that initial phase, being able to send residents even with mild symptoms to hospital assisted you in responding to the outbreak? Is that what you've just been saying to us?
So the first component is that there was an agreement that they go to hospital to ensure the support and the care of the resident. There is no doubt that in doing that assisted our outbreak management because at that time we were looking to manage our surge. We had to implement a surge workforce as well, and ensuring that the operations were consistent, so that when in the second week, New South Wales Health had conversations with us around the appropriate transfer and not transferring all COVID positive residents. We had a stronger support service at Dorothy Henderson to manage that process.
All right. Can I just understand the first point there? How did it help you in managing the outbreak? In that first phase?
It allowed us to understand our containment. So we were trying to manage incubation periods and isolation of residents. So taking people who didn't have a COVID positive, people who were COVID positive who went to hospital, that obviously allowed us to say that the service had no active cases at that point. And it certainly supported encouraging staff to come as well, because at that time, staff were fearful to come on site. So we had to work strongly and support our staff to ensure their safety, and not having COVID positives helped that in the initial phase. As we moved on and staff felt more assured to the processes, that became less of an issue.
Understand. And can I ask, with the residents that were transferred, without focusing necessarily on the ultimate outcome for them? Because we know a number of them passed away in hospital, didn't they? I want to try and get some sense from the two of you very experienced aged care practitioners about the practicalities associated with moving, for example, residents that may be suffering from dementia or may be particularly frail. Can you reflect on the challenges that presented to you as a provider? Starting with you, Ms. Dix.
Absolutely. As you say, that there is a number of people who live in aged care facilities that have a cognitive impairment. So changes or rapid changes to their environments or unknown environments is highly distressing to them. So we certainly try and work with the provider that they're going to or the health service that they're going to and determine the need for transfer and trying to understand what the outcomes that are trying to be achieved by that transfer, working again with the families. So we were able to do it on a case-by-case basis, and that's certainly our preference, that we understand what the resident or the decision maker is looking for the care provided to the transfer, because confusion is distressing for someone with a dementia diagnosis.
It seems, certainly compared to many other facilities, that you were quite successful, and Professor Gilbert says as much in her report, quite successful in confining the outbreak. I think ultimately there were 16 COVID positive residents out of, what is it, about 80 people that were living there. Was that, are you able to say whether the ability to hospitalise that first group in that first week helped you limit the spread?
Absolutely. I don't think you could say anything less, that anybody who was COVID positive going there in the first place ensured that they got the care that they needed, and then it allowed us to actually stabilise our workforce as well. So it worked in two fashions for it, and then it also allowed us initially to identify areas of containment within the building that may be following the incubation periods that may be COVID negative. So that it did assist in that initial process, absolutely.
Sorry, Ms. Lowe, can I ask about the impact of that approach on the negative residents? How does the hospitalisation of at least some of the positive patients impact on your ability to provide for the care needs of what is, of course, the overwhelming majority of residents that you had there, for whom you're still responsible to provide care needs? Are you able to reflect on that?
I think everybody's received the same care. I need to understand your question more, because I think everybody received the same level of care and support. And people were required to remain within their rooms for the period of time because there was still an incubation period that we needed to work through. And that's certainly that concept of people remaining within their rooms and that being a distressing process within itself. Removal of people to a hospital does allow to put a finite time on incubation if there's no more positives within the building.
Yes, thank you. Is there anything you wanted to add to that discussion, Mr. Lowe? From
only in a sense that in that second time, we were certainly able to take into account the resident and their family's view on whether they did or didn't want to be transferred to hospital. And I think, as you drew the conclusion this morning, there were a number that didn't. And in fact, 2 of our residents of the 6 actually passed away at the facility, with their loved ones being able to be accommodated and visited by the family, appropriately PPE'd, but they had that opportunity to say farewell to them and spend as much time as they wish to at that particular point.
Does that, Mr. Lowe, emphasise the importance of residential aged care facilities being able to provide high quality palliative care?
It does, and that's something that our people are trained on, is to provide that palliative care, yes.
Yes, thank you. If I could turn to the other submission that Baptist Care Australia provided, which is behind tab 15 of the Dorothy Henderson Hinder bundle. Do you also have a copy of that handy? You do?
Yes,
You've been very well prepared. We're grateful to your legal team. If you could turn to page 8 of that submission, please. You'll see the page numbers in the top right-hand corner. the last digit of a long code should be 8.
Right.
And there's a heading, Care Reserve Team Surge Workforce. I meant to ask you about this earlier. Do you see in the middle of the page, there's a second bold paragraph that starts recruiting members of care reserve teams from unorthodox sources of labour have also provided some unexpected benefits. Do you see that?
Yes, yes, we did.
Is that something you can speak to, Mr. Lowe?
Yes, I think it was an excellent decision in that obviously quite a number of areas, like running camps, people running restaurants and chefs, etc., were out of work. And therefore we were able to tap into various areas and provide a good workforce who we then trained and buddied them with others within our facilities, not Dorothy Henderson Lodge, but in other facilities, so that they would gain the experience that if we needed to have more workers, staff moving across to Dorothy Henderson, then these people that we'd taken on board as our reserve would have been able to fill those gaps. So it worked, we believe, very well. And in fact, we've decided with potentially a second wave maybe hitting New South Wales, that we've kept that reserve workforce on, and we will have a review of that on a monthly basis. But at the moment, we're keeping them on just in case something turns for the worst in New South Wales.
Does that, the success of that initiative, Mr. Lowe, does that have potentially two broader implications for the aged care sector? The first one being that the sector needs to think laterally about sources of labour, increasing the size of the workforce. And the second is that, as we all know, one of the very terrible effects of the economic impact of the pandemic in Australia is to leave a lot of people out of work, people who might perhaps never have thought of careers in aged care. But do you think there's an opportunity for the nation there to be perhaps retraining and maybe encouraging some of the unemployed part of the workforce to be coming into aged care at a time when it's so desperately needed?
I think it's been a very good example of that, and certainly would encourage. Obviously, sadly, it comes at a cost, but I think we believe that was a very good insurance policy in a sense, to make sure that we had sufficient staff to meet any particular outbreak. And I guess at that point, we're also sadly thinking about could there be a second outbreak in one of our facilities, and therefore that reserve workforce would provide other staff to be able to move across into the second facility should it eventuate.
Ms. Dix, is there anything you'd like to add to that discussion from your regional manager perspective?
I think the only thing to add to that this program worked very well, and I think what would complement it, given the current situation of outbreaks that is occurring, is ensuring those that are coming into aged care are valued for what they are doing. This is understanding the value that people, if they work in this industry, can make to older people's lives. And everybody works to respond to their values, and I think that's an important message that we can share with other people when they work with us in our aged care.
And to reinforce that, I think we've had a number of those reserve workforce people say, would there be opportunities potentially for us going forward? So I think they've begun to understand the value that they can add to the aged care environment.
Thank you. If I can turn to the topic of governance, which is addressed on page 14 of the national submission. If I could ask you to turn to that, please. You'll see the heading a third of the way down the page, leadership and governance practices that have been used by Baptist Care Australia members to respond to the crisis. I'm interested in what the lessons more broadly are for the kind of governance arrangements that are needed to respond to crises, whether they be pandemics or bushfires or any other sort of crises that might occur. The one thing we know in this country is that something like that's around the corner. We don't necessarily know when or what, but we know it's coming. So what are the lessons? There's a reference to the need for equipping leaders to be capable of agile and fast-moving action in a time of crisis. Are you able, particularly you, Mr. Lowe, from your position within the organisation, to reflect on what you and perhaps the board have learned about these issues from the pandemic?
Yes, I think the great learning for us was that we were able to put very senior people into Dorothy Henderson Lodge who could immediately make decisions that were appropriate and feed that back to the crisis management team to work through. And we were very fortunate also to have the chair of our board join us right from the Tuesday evening. And he stayed with us, not to necessarily manage us, but to ensure that decisions that we made were appropriate. So the ability that we had right across the board of having agile senior people being able to make decisions, I think was one of the great advantages that we saw coming out of the way that we dealt with the outbreak at Dorothy Henderson Lodge.
Ms. Dix, is there anything you'd like to add to that? Or
I think probably just reflecting on my previous comments as well, that stakeholder collaborative approach where people are clear on their responsibilities from both the health services and the government agencies at the time of the commencement of the crisis is very important. What roles and responsibilities, who has the capacity to make decisions and assess at that particular point what resources are available for the outbreak plan.
Thank you. Ms. Dix, I think you may have wanted to make some further general observations. And I don't want to cut you off, but I know you did earlier make reference to a number of key lessons that emerged. Is there anything else you wanted to add at this time?
No, I know, because it is reflective of that particular comment. What was critical to our outbreak was actually the collaborative framework we had with our stakeholders, the approved provider, the health services and the government agencies. And what's very important is to be able to do a capability assessment of being able to implement the outbreak plan and what resources are needed, and making an assessment of when those resources are challenged, what would happen next for them. So I wanted to raise that with the Commission.
I've now reminded myself that there was another matter I wanted to raise with you, and it's dealing with this management issue. I touched on it earlier, and that is that you were part of a team that moved into Newmarch House on the 24th of April. So I think it was day 13 of their outbreak. Can you just tell the Commissioners briefly how that came about? What led to that?
Absolutely. So key staff from the Dorothy Henderson outbreak was seconded, Baptist Care staff was seconded to Anglicare at the request of the Aged Care Quality and Safety Commission. And our role was to go in and provide some experience, because we had it in so recently, and support to the Newmarch Anglicare service whilst they were in the middle of their outbreak.
What were the particular issues that were drawn to your attention as needing your attention as part of that team?
So prior to going in, there was an understanding that it was a complex situation in terms of multiple stakeholders and multiple agencies involved, and coordinating and working with those agencies to work to focus on Anglicare was one of the first ones. They had, at the time that we went in, they had just implemented an external surge workforce as well, and there were some challenges around infection control management. So we took some support and expertise to address those areas.
Their workforce was from a more diverse range of employers than you had to deal with. You at Dorothy Henderson, you had some staff that had come from other Baptist Care facilities, and you had the provider Healthcare Australia, and that was challenging enough, presumably, to respond to. At Dorothy Henderson, at Newmarch, it was a different level of complexity. They had staff from Mabel, they had staff from Aspen, they had other existing staff that they were dealing with. What are the particular challenges for a manager, especially one coming in new that you experienced, and what are the lessons from that you're able to share with the commissioners?
So the challenge, you're absolutely correct, to have multiple staff come on site who had come from different organisations, who had various levels of competencies and knowledge of the situation. So the first challenge is to ensure that anybody who's coming on site understands the competencies and the procedures and the operations model that was being implemented as a result of the outbreak. So that was a very clear challenge. So we had to move to a leadership model that was much more command and control, to be very clear, and we need to simplify the processes as well. So that management of staff was absolutely a challenge for Newmarch, because they were coming from so many areas with varying competencies.
One of the other key differences was that at Newmarch, the model of response, if I can call it that, was hospital in the home, which is not something you'd had experience of at Dorothy Henderson. Are you able to reflect on how you saw that working, and anything that you think ought to be done in future that might make hospital in the home work better in an aged care facility?
One of the key things that we implemented when we went on site, and it was as a result of an experience of Dorothy Henderson Lodge, was that aged care services often run electronic care management systems, which include documentation. When you start to have a number of staff coming from external agencies, those staff will not have knowledge and capacity to access those electronic management systems. So we moved to a paper-based system. That's a business continuity process that we had implemented at Dorothy Henderson. But that had a massive impact to the hospital in the home program as well. So the lessons of implementing a care model such as hospital in the home is understanding the parameters and the resources that are required to implement the program. And two of the key challenges that we created through trying to manage the outbreak made hospital in the home difficult. So the hospital in the home couldn't see the care management documentation, and we had a new staff that didn't fully understand what the hospital in the home model was, and we needed to continually orientate those staff as well. So those type of programs need everybody understanding all the roles and responsibilities for both the service and the hospital in the home for them to work very effectively.
I don't think it's any secret that there were some challenges with communication during the Newmarch House outbreak, communication with residents, with their families in particular. Was that another area of your focus when you went into Newmarch?
We helped as part of that process, but certainly Anglicare was focused on managing the whole communication management program. We helped to provide operational suggestions and implementation of some programs. So, for example, the residential manager had identified that registered nurses communicating with families would be beneficial in the situation that had presented itself, and as a result of support with the Commonwealth, there was a registered nurse call centre implemented within the building.
Finally, Mr. Lowe, can I just bring you in on those 2 points that I've been talking to Ms. Dix about? The first one being the experience with the digital records and moving to the paper-based system. There's a bit of discussion about that in the submission. Are you able to reflect on what the lessons are for providers generally of that, the importance of backup to any digital record keeping system that you've got?
Yes, I don't think we had envisaged that when you completely lose your workforce and you have agency staff come in, that they do not understand your electronic clinical system, which then in fact had to be downloaded into a paper system. All our business continuity plans up to that point would have envisaged that system going down for a technical reason for 2 or 3 days and then be able to be resolved. But to have to go back to a paper system, which then didn't prompt people to do things with particular residents, because that's what the electronic system does, it was a challenge to work through both the paper system and the lack of prompting that was available from it. So yeah, it was a real challenge in that sense. And I think to the industry, they should contemplate how they will operate if they do not have anybody that understands their system working for them at that particular point in time.
Yes. And the second issue was about communication. In your submission, there's a reference to the importance of openness and honesty and transparency in communication. No spin, perhaps, if I can put it that way. Can you reflect on how that worked at Dorothy Henderson from your perspective?
Yes, I mean, I think one of the things that we highlighted in our submission was that we believe we handled communication very well. It's something that, in a sense, took an enormous amount of time. We had about 5 or 6 people in our marketing area working non-stop on communicating both out to our residents and their families, to our staff members, and the general public and stakeholders on a very regular basis. And I think keeping them informed, not always being able to completely, pacify them on certain issues, but keeping them informed on how we are, what we're doing. I think at the end, and you saw the number of compliments that were beginning to come through, particularly as we moved to set up a connections coordinator, which allowed us to have the ability to work with the individual resident and their family to be either receiving of emails, working and talking to them on the phone, FaceTiming them on iPads. That really did help the communication, and I think allayed quite a number of the concerns. We then also moved to setting up safe visiting areas, and that allowed us to again provide that opportunity for the family to come and see their loved one within the facility.
Last topic from me before I ask the commissioners if they have any questions. First, you, Mr. Lowe, from the CEO perspective, are you able to share with us any reflections on the impact of the pandemic on your home care, on the home care side of the business?
I think, yes, the immediate issue in the first place was that quite a number of our clients took the decision not to require a service until they completely understood the impact of COVID-19 on any of our operations or people in the community generally. So therefore, immediately, we had a significant reduction in a number of hours that was being planned, and we had to determine how to, work those through, because we didn't want to lose any of our good staff. So we actually agreed to pay them an average pay rather than the actual hours that they were earning during that particular time. I think that had a positive impact on the future as it starts to come back, and we've got therefore the same staff member being able to work with the client as we go forward.
Ms. Dix, is home care part of your responsibility at all?
No, it's not.
All right. Thank you. Commissioner Briggs, do you have any questions for Mr. Lowe and Ms. Dix?
Thank you very much for that evidence. It's been interesting to hear the comparison between your home being at the beginning of the pandemic and Newmarch, right when it was going crazy in New South Wales. And that leads me to ask the question about what would you do differently if you were one of the homes in Victoria, knowing full well we've got about 1,000 people in residential aged care in Victoria infected with the disease?
I think that's not an easy one when you don't know the full circumstances of each of the facilities. But, perhaps the preparation, the learnings were not picked up quite as well. I guess it would be hard for me to make an observation sitting here. I wouldn't want to look as though we're being in any or form smug about where we are, because I really do desperately feel sorry for the situation down in Victoria. And I think anything that we can do to help is something that we can do. But no, I don't think I can add much value at this particular point.
I suppose I badly phrased my question, I think. I really want to follow up the issue of hospital transfers and whether in the circumstances where you've got 1,000 people in residential aged care with the disease, whether hospital transfers for everybody becomes an impossibility. And I'm assuming it is.
I can make some statements in relation to that. I think when you have a need to that size, what's important is to understand the resources and the support available. That it can be about supporting a resident whether they remain in an aged care facility or go to a hospital. But it's understanding what resources are there. What is the capacity of the workforce? What are the other community health support services that are available to be part of this solution as well? And that's certainly the learning that I have from both Dorothy Henderson and Newmarch is a clear framework of collaboration with the right people involved, making frank assessments and understanding what resources are needed to make that happen. I think that's a lesson that you could learn at any point in any outbreak, to say how many people, how much have we got in terms of staffing and support? What other healthcare support services do we have in relation to this outbreak? And then develop some solutions from there. So I don't think it's an absolute solution. It's a solution based on the time and the resources and the capacity of the moment.
Thank you. That's all from me.
Commissioner Picconi?
Ms Dix, I wonder whether I might partly follow up that question by just asking, you said earlier on that one of the difficulties with transfers was that it can be very distressing to the resident. Can you just expand a little bit on the degree of distress that we're talking about and the potential consequences?
So I was referring specific to people with a dementia diagnosis, where a change of environment and a move to an environment that lacks familiarity and not having people who they are familiar with does increase that distress. And so certainly when we provide supportive care for people with a dementia diagnosis, we try and maintain an environment that they understand and feel a level of comfort with.
Thank you. Mr. Rose, anything?
No, nothing further, thank you, other than to thank the witnesses and ask for them to be excused.
Yes, thank you. Mr. Lowe, Ms. Dix, thank you very much for the evidence that you've given today and for all of the work that's gone into the submissions in the past and in preparing for the evidence that you've given today. It's been very, very helpful. We're very grateful to you, and we're very grateful to you in particular because of the circumstances in which you're participating, and I know that they've been difficult. So thank you very much.
Thank you.
And I formally excuse you from further attendance.
Thank you.
Is there counsel that also needs to be?
Yes, there probably is counsel that needs to be excused.
May I be excused, Commissioner?
Yes, I can't see you, but, but yes, you are. Yes, there you are. I can see you now. Thank you.
Thank you.
And you are excused also.
Thank you. I'm assuming the wonders of technology enable us to just go straight to the next witness.
We should do.
No one's telling me otherwise. I call Professor Lynn Gilbert.
Do we need to go, Tim? Or? Yeah.
Professor Gilbert?
Right, I think I'm sorry about that.
That's all right. We've mastered the technology. You can hear me all right?
Sorry, I can't hear you very well.
Oh. Is that better?
Not really. Maybe I should just do without my...
You're certainly very clear. I'll keep talking and you can let me know if I become more audible.
We're right now.
We're good? You can hear me clearly?
Yes, thank you.
Thank you. The next voice you'll hear will be Ms. Amundsen's.
Professor Gilbert, do you solemnly and sincerely declare and affirm that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please
Yes.
say I do.
I do.
Professor Gilbert, for the transcript, can you please state your full name?
Gwendolyn Gilbert, commonly known as Lynn.
Right, thank you. Professor Gilbert, you are a physician. You've practiced in relation to infectious diseases since 1991, is that right?
Well, I've been in Sydney since 1991, but I practiced in Melbourne for 20 odd years before that.
Okay. Did seem a bit recent, I thought. And you're an honorary professor at the University of Sydney as part of the School of Medicine.
Yes.
You are a member of the Infection Prevention and Control Expert Advisory Group of the Australian Health Protection Principles Committee.
That's correct.
And you've held that role since 2014.
Yes.
I'm doing your very impressive CV a great disservice, I think, but that's an adequate summary for our purposes, or is there some other qualification that you'd like to add to that?
No, that's fine.
All right. Now, you've been kind enough to provide us with your CV. For the record, it's tab 9 in the witness bundle, and I should probably tender that, Commissioner. It's RCD 999904 03 0005. It's not part of any existing exhibit.
Well, that'll be exhibit 18-6.
Commission closes. Professor Gilbert, you have completed a report in relation to the COVID-19 outbreak at Dorothy Henderson Lodge, is that right?
That's correct.
I want to ask you a little bit about that if I could. It's part of the Dorothy Henderson Lodge tender bundle behind tab 10, Commissioners. Do you have a copy of that in front of you, Professor?
Yes, I do.
If I could ask you firstly how you came to prepare that report. Was that at someone's request?
With Professor Brendan Murphy, who was the Chief Medical Officer at the time,
yes,
asked me if I would do a review of Dorothy Henderson Lodge outbreak to try to determine what lessons could be learnt from it.
Right. You had some role in responding to the outbreak, had you not?
Well, in the sense that I had chaired the infection control expert group from the beginning of the outbreak.
Yes.
And I had had a very peripheral role in training of healthcare workers in preparation for that, largely as a side effect of some research I was doing in infection control training with a small research group, Westmead Hospital, but mainly in the role of infection control expert group chair.
Yes, I just want to clarify this if I could. It's not a huge matter, but there's a reference in the Baptist Care submission that's been provided to the Royal Commission to an expert panel review committee that was established in the course of the response to the outbreak at Dorothy Henderson Lodge, and amongst many people on that expert review committee, your name appears. Is that accurate? Did you participate in a committee that was specifically responding to the Dorothy Henderson Lodge outbreak?
No. My role was just as a single reviewer,
Yes.
without any other review without anyone else involved. It was a fairly quick and not very much in depth review just by me at that stage. I wasn't involved in any committee in relation to Dorothy Henderson Lodge.
Now, I understand that there was no committee involved in preparing this report. I think we might be at cross purposes. My question is, before any question of you doing a report arose, were you involved in any way in responding to the outbreak, in assisting Dorothy Henderson Lodge to deal with the outbreak?
No, I wasn't. All I knew about Dorothy Henderson Lodge when Professor Murphy asked me to do this review was what I had read in the media.
I understand. And I mean, I take it that from the role you perform in advising the AHPPC on infection control matters, that given this was the first residential aged care outbreak, it was a matter of quite some significance in Australia's general response to the pandemic.
The infection control expert group had prepared some guidelines for residential aged care facilities based on the Communicable Disease Network outbreak plan,
Yes.
but with more detailed infection control guidelines, but really based on basic principles of infection control rather than any specific experience of COVID-19 in aged care facilities.
Were you listening at all this morning when Professor McLaws was giving evidence, Professor Gilbert?
Yes, I was.
Do you recall I asked her about the differences between responding to an influenza outbreak in a residential aged care facility as compared to responding to a COVID-19 outbreak? Are you able, from your position, to assist the commissioners in understanding the differences between those two?
Look, I agreed with what Professor McLaws said largely. I mean, the difference, there's been a lot of comparison between influenza and COVID-19, and there certainly are some similarities, but the main difference, I think, with COVID-19 is that everybody in the world, when it started, was completely naive. None of us had been exposed to it. There was no previous infection, no immunisation. And it's probably a bit comparable. I mean, there are a lot of other differences for other reasons, but it's a bit comparable to the 1918 influenza pandemic, when a completely new influenza strain was circulating around the world and nobody really had any past exposure or immunity to it. With influenza, we are certainly familiar with, and I'd been peripherally involved in my previous role at Westmead Hospital as in giving advice and diagnosis and so on of outbreaks of influenza in aged care facilities. But as Professor McLaws indicated, at least some, regrettably not all, but at least some aged care facility staff were immunised. Most of them, all of them, would have had previous exposure to influenza viruses, which, whilst they differ from year to year, and which is why we need annual immunisation, nevertheless, there is some immune memory to previous influenza strains, and all of us build up a certain level of resistance to severe influenza infections, except for young children who haven't ever been exposed before, and elderly people whose immunity begins to wane as they get older and who don't respond as well as younger people do to immunisation. And so that's why older people are at risk from influenza, and particularly if they happen to have underlying chronic disease of one sort or another, they may develop quite severe and potentially fatal influenza infection. But they're a minority generally.
Yes. Can I start at the end of the report, if I may, unusually perhaps, and ask you about some observations you make on the very last page, which is ends in .7122. It's page 9 in the bottom right-hand corner, if that helps you, Professor. Headed appendix, sources of information.
Yeah.
Do you see 4 lines down towards the end of the 4th line? You've written, this report may need to be modified after they, that is, the people with whom you consulted in its preparation, have had an opportunity to review it and correct any misinterpretation or errors. Can I ask whether the version the Royal Commission has is in fact the final version of this report?
It's the version dated April the 14th, if that's the one
Yes.
you've got.
That is the one.
Is the final one. I have to confess that I didn't check this with everybody that I'd obtained information from, but the 2 people who did help me a lot with information and who checked this final version were Melanie Dix from Baptist Care and Kathy Dempsey from the Clinical Excellence Commission, neither of whom had any problems with this version.
All right, thank you for that. Can I just ask you about the next line, and I'm wondering if there might be a typo in the 4th word. Unsurprisingly, there was. Should that be little documentation at this time to support the information in this report? Should the word like be little?
Sorry, where are we looking at here?
So just immediately after that sentence that I asked you about, the last sentence in the first paragraph starts unsurprisingly. Do you see that?
Yes.
Yes. And should the word like, the 4th word, should that be little?
Little, yes,
Little.
I'm sorry, that's right.
No, that's absolutely fine.
Yes.
Thank you. Can we go back, please, then to the start of your report? And there's a heading, Lessons Learnt, at the bottom of the first page.
Yes.
And you observe there, first dot point, the response of Baptist Care management and staff to this outbreak was prompt and thorough. The outcome probably would have been worse in a less well-managed facility with fewer resources and facilities. I just want to ask you a little bit about that from your perspective, and you've now been observing the responses to COVID, not just in Dorothy Henderson, but more generally in Australia and in aged care generally. What is it about the level of managerial competence that is important here in relation to responding to COVID? What aspects of good management bear upon the thoroughness of the response of an aged care provider?
Look, I think that, and obviously I was coming into this after the event, but my impression was that right from the start, the Dorothy Henderson Lodge senior managers were not only involved, but on site at the facility directing procedures. They seemed to have clarity about whose responsibility it was to do different things, to make decisions, and they got on with it. And they collaborated with New South Wales Health, who made the suggestion, and to their credit, Dorothy Henderson Lodge immediately accepted the suggestion that they have immediate expert infection control advice, which to me was one of the most important aspects of this. But I really do think that given the difficulties, and there were enormous difficulties in this and other outbreaks at the time, that when a lot of the permanent staff of Dorothy Henderson Lodge had to go on leave because they'd been contacts of either the first 2 cases in amongst staff or the residents who were already infected when they were first recognised. They lost a lot of their permanent staff, and the managers were willing to not only take control but pitch in and actually help with the care of residents. and they seconded volunteers from the other parts of the organisation to help with this. So that it was that decisive action very early on, and the fact that they were prepared to do whatever was advised by the infection control professional to implement good infection control were the major factors, I think, which were very important.
Thank you. I can just perhaps if I could unpack that a little bit, because we've already heard from witnesses this morning about the importance of infectious control expertise. I take it what you're saying to the commissioners is one of the hallmarks of a good managerial response to a crisis like this is to know what help you need, to be able to identify quickly what the gaps are in your skills, and to take on board any offers of assistance that are made to you. Am I capturing correctly your message?
Look, yes, absolutely. And I think there's a mistaken belief amongst a lot of aged care facilities that because their staff have done an online training program, or maybe had a single session about how to put on and take off personal protective equipment, that they have done enough in relation to infection control. And unfortunately, that's not true in aged care. It's not true in hospitals, for that matter. Yeah. There's a lot more to infection control than personal protective equipment. There's also context-specific aspects that really depend very much on having an infection control expert to size up the immediate situation, the physical layout, the environmental controls, and so on, to determine exactly what needs to be done. And I don't think that any individual, or I shouldn't say not any, but most individual aged care facilities would not have that expertise, even though they may have done all that they were required to do by the regulation in terms of having an infection control protocol and having done basic training of their staff.
I wonder if I could just ask you to expand on that a little bit. The evidence before the Commission is that in response to a self-assessment survey that providers engaged in March of this year, the responses were generally fairly positive in terms of the perception that providers had about their, for example, infection control arrangements. Do you think, with the benefit of hindsight, no doubt looking back now, that there was a degree of naivety within the sector about what preparedness for a COVID-19 outbreak actually required?
Yes, I do. And that's partly because nobody really knew, nobody could have quite anticipated what COVID-19 was going to be like. So in their defence, I don't think they could possibly, and nor could infection control experts necessarily have predicted what was required. But I think the other problem is that the general community, the management and staff of aged care facilities, and also the management and staff of many hospitals really assume that everybody more or less knows what infection control involves, that it's pretty obvious, doesn't require a lot of expertise. And unfortunately, that's a misconception that I think carries over and is included in hospital management priorities, if you like. And most of the time, hospitals, aged care facilities get away with it because they don't have many outbreaks. And when lapses of infection control occur, there are delays and you don't necessarily recognise how that happened. But we do know that there are still a significant number of healthcare associated infections and of transmission, just as an example, transmission of multi-resistant bacteria amongst the residents of aged care facilities. And we know that outbreaks, obviously, of diarrhoea and influenza occur as well. So, you know, the fact is that most of the time, routine infection control with all its flaws is more or less okay, but in a crisis, it really needs a sort of experience and expertise of an accredited infection control professional.
You mentioned that these gaps in infection control systems can be found in our hospitals as well as in our aged care facilities, and it's an important reminder for us. Is that those gaps, do you think, do they explain at least in part what seem to be large numbers of healthcare workers that are contracting the virus, particularly in Victoria at the moment, or is it too early to gauge what the reason for that is?
Look, there've been lots of concern and queries about why so many healthcare workers are getting infected with COVID-19, and unfortunately, we really don't have a lot of details. We do know that there's a significant proportion, and particularly in the first wave of COVID-19 in March and April, a significant proportion of the healthcare workers who were infected were quite clearly infected in the community or from overseas travel.
Yes.
Some of them were certainly infected in hospital settings, but there are many reports, and unfortunately they're largely anecdotal at this stage, but a lot of them, that healthcare workers may have been very careful with their infection control and the use of personal protective equipment when they were actually in the wards caring for patients. But when they go out to the tea room or a meeting room, they mix with their colleagues, forget about PPE, and didn't at that stage at least need to wear PPE, and were not remaining physically distanced from them. So it's very difficult to unpack exactly when and from whom they acquired infection, and I think we're still working through that at this stage.
Thank you. Just focusing back on the observations under the heading Lessons Learned, the second sentence in that first dot point reads, spread of COVID-19 is very difficult to control in a household-like residential setting with highly vulnerable residents. Why is that so, in your opinion? What are the difficulties associated with controlling the spread?
Well, there's been a lot of emphasis in recent years in residential care facilities in making them home-like, in carpets, soft furnishings, having residents bring as many of their treasures and possessions into their rooms as they want, mixing with each other, socialising, and of course with the staff, they often need very close care, physical care, hands-on care. So in that sort of setting, it's very physical distancing is difficult, and just the sort of in cleaning and I guess environmental cleaning and uncluttering, if you like, that we would expect in hospitals is not possible or appropriate in an aged care setting. And people are physically close together, they mingle with each other, and I think that's a problem which is just not means it's not easy if one of them happens to be infected with an infection like COVID-19 to prevent it spreading to others.
Thank you. Can I ask you about what we could do, what the aged care sector could do to improve access to the sort of high-level infection control expertise that you're referring to in your report? We know, for example, that we've heard this morning that at Dorothy Henderson Lodge, they had access to that type of expertise through Kathy Dempsey on day one, whereas the experience at Newmarch House, as we understand it from Ms Dix, was that was a very different scenario where that type of expertise wasn't available until some 13 or 14 days into the outbreak. I take it from your perspective that that's an important difference in terms of the ability of the facility to respond to COVID?
Look, it's an important difference. I don't know that it's true to say that the expertise wasn't available at Newmarch. It wasn't sought, as far as I know. The problem is that there aren't an unlimited number of infection control professionals able to provide this advice at short notice. It's hard to know how to resolve this. I think one of the ways is that there are certainly infection control professionals within hospitals in the local districts that could probably provide advice and training to staff outside of this outbreak scenario, which would make everybody more prepared to respond quickly when the situation arises. But whether there are really enough infection control professionals at the moment to actually do that for every aged care facility is a little bit difficult to tell. It's quite possible that a large organisation like Baptist Care or Anglicare could employ someone who would be in a position to take care of multiple facilities, train staff, assess preparedness and so on an ongoing basis. I think the real problem is that this can't be done adequately in a crisis in more than a very few settings. And Dorothy Henderson Lodge, I think in many ways was lucky in the sense that there were no other very urgent calls on Kathy Dempsey's time. But it's something that needs planning in the future, I think.
You mentioned earlier the notion of accreditation of infection control experts. Can you explain to the commissioners how that works? Who does the accrediting, and are there grades of accreditation, and how many people are actually out there that have this form of accreditation?
Look, I can't tell you the details of this, but I do know that this is a relatively recent thing in Australia. The Australian College of Infection Prevention and Control was formed only about 10 years ago, possibly less than that, I'm not quite sure exactly. And it has done an enormous amount of work in developing courses and accreditation procedures for infection control professionals. Up until then, a large proportion of our hospital infection control mostly nurses, were people who had either done courses online, done courses overseas or interstate, or had learnt on the job. And there really was very little provision for their proper training. The Australasian College now has to a large extent filled that gap, but there are still problems with many hospitals not offering jobs for enough infection control professionals to, first of all, provide a large enough workforce for when these sorts of situations occur. But in many people's opinion, and this is something that's hotly contested, even providing most hospitals with enough infection control professionals to do the sort of ongoing training and implementation of infection control programs within hospitals. I think all of us involved in this field would like to see a lot more infection control professionals employed in our hospitals and the hospitals requiring that they are accredited, which means that then there would be more available for this sort of situation.
You mentioned earlier the possibility of the accredited infection control practitioners not just assisting in responding to an outbreak, but assisting to plan for an outbreak and to provide training. Is there scope for a type of train-the-trainer approach here where you'd have a designated infection control officer within a residential aged care facility, or a champion, I think is sometimes the expression one sees. I'm not sure if that's you or Kathy Dempsey that uses that expression in their in the reports. But that way we get more bang for our buck, if you like, from that scarce resource. The Kathy Dempseys of the world are able to train others, who in turn can then become the infection control guru within a particular facility. Is that an approach that you think might work? And do you have any experience overseas where that does work? Hong Kong comes to mind, where since SARS, that is a requirement in their care homes. Are you able to assist us in relation to that?
I don't have any experience overseas, but it's a model that has been trialled and is supposed to be implemented in hospitals, for example, where every ward is supposed to have a link nurse who has extra training in infection control and is the champion for infection control in their own ward. Unfortunately, it doesn't always work because sometimes the wards are so busy they just don't have time to do the additional training and so on. But I know that at Newmarch, Kathy and the team that came in later identified people within Newmarch who received extra training and who were, and some of them had previous experience with infection control, who came in from agencies and were the champions at Newmarch, which I think is absolutely right. I mean, that's the way to do it. You can't necessarily have a credentialed infection control professional, certainly not full time in every aged care facility. That would not be cost effective. But to have someone who is a consultant to an aged care facility, who may be someone who works in a local hospital or as a private consultant, but whose job is to train a small number of relatively senior staff, one would hope, and permanent, not a transient workforce, but people who are likely to stay in the facility, and then be a resource when they need help or whether they need refreshers and so on. Yes. I think that's exactly the way it should be done.
Yes. And is that something you'd like to see made mandatory, or is it something that would be better done by way of encouragement for the sector, or do you not have a view about that?
Well, look, I have a bit of a sort of philosophical position that if you think something's really important, and particularly if it costs money, which infection control does, not a lot, and it's highly cost effective, but it nevertheless is an extra cost, then you almost have to make it mandatory for people to do it. It just seems to me that for many facilities, particularly as I understand it, are running very close to the line as far as their budgets are concerned, it would be very difficult to expect them to do it unless it was mandatory, and then there has to be a way to facilitate that.
Yes. Is the other side to that from a risk control perspectives, the consequences as we are seeing on a daily basis of not having adequate infection control in aged care facilities is that the costs associated with that in terms of human life are very high. Is that another reason?
Yeah, the financial costs are very high too of these outbreaks.
Yes.
Well, of course that's true, but then that's always been true of most preventive measures. We know that when they work, they don't cost anything. The consequences are not a problem. It's when they fall short that it becomes expensive, but the expenditure has to be before that. And I think a lot of people hope it won't happen to them.
Yes, that's human nature, I think, to some extent, Professor Gilbert. Another point that you make on that same page of your report, this is page 6 that I'm looking at actually, page 19 in the coding we have. You'll see page 6 in the bottom right-hand corner. You see that?
Yeah.
There's a heading in the middle of the page, IPC and medical support during an outbreak, and you there refer to...
We're looking at different pages somehow.
Are we? It's
I've got it here.
Just page 6 in the bottom right corner.
My copy, but maybe I anyway. I found the heading now. Yes, sure.
All right, terrific. I wanted to ask you about the section that's starts with the words medical support in bold. Do you see that?
Yeah.
It's about 2/3 of the way down the page,
Yeah.
in my copy anyway.
Yep.
Medical support. Soon
Yeah.
after the outbreak, an infectious diseases physician offered his services, and so on. We know that's Dr. James Branley that did that. And you refer to the significance of his confidence and his authority, which helped to reassure staff. And we heard the same thing from the Baptist Care witnesses just a few minutes ago. I want to try and understand from your perspective how the skills and experience of the infection control consultant, so that's Kathy Dempsey in this example, and the infectious diseases physician, how do those skills complement each other, and why is that important? Why was that important in the response at Dorothy Henderson?
Look, I think particularly with COVID-19 and that at that stage when there was so much unknown about it and there was so much fear in the community, James Branley's, the fact that he'd been in Wuhan, he'd contributed to the team that brought Australians back from Wuhan, and I think he's someone who has had a large experience with infectious disease management. Must have been very reassuring both to the Dorothy Henderson Lodge management and to the staff, who were, I understand, and this is before I was involved, but who I understand were understandably fearful of coming to work, and some of them just didn't turn up, and those who did, I think, were tempted to leave. So his sort of confidence and authority must have been very reassuring. But he also was able to and willing to actually assess the residents who became ill, to make some clinical decisions about what to do about their care, whether they needed to go to hospital and so on. And I think that was very important particularly in the earlier stages of that outbreak.
Thank you. At the top of that page, you make some reference to hospitalisation of residents, and the evidence we've heard today was that in the first period of the outbreak at Dorothy Henderson, there was a policy of hospitalising all residents who tested positive, even those with very mild symptoms, where it might not perhaps have been clinically indicated that hospitalisation was necessarily required for looking after them. And that later that changed. There was a more case-by-case analysis of whether hospitalisation was needed. The evidence of Ms. Dix was that in those very early stages where they were scrambling to staff the facility from different sources, that it was advantageous to them to have those residents hospitalised. Do you have any views on that from a general perspective, or both in relation to Dorothy Henderson, but also more generally?
Look, I do, and it's been something that I've been struggling with in relation to both Dorothy Henderson and Newmarch. I certainly thought that, and I still do, for Dorothy Henderson Lodge, in those first few days when they were very short of staff, and it must have been really hectic trying to just care for just the ordinary day-to-day care of residents, let alone others who were ill, even mildly ill, would have been very difficult and would almost certainly have increased the risk of breakdown of infection control. And I think, as it happened, several of those residents who developed COVID-19 early in the outbreak at Dorothy Henderson Lodge were actually quite sick anyway and needed to go to hospital for other reasons. But one of the principles of outbreak control is that you've got to not only control or prevent transmission of infection from people who are infected to those who aren't infected, but if possible, you need to control the source of the infection. And that usually means isolating people away from others who are not infected. And to do that in an aged care facility, even in a setting like Dorothy Henderson Lodge, where they all had separate rooms and with ensuite bathrooms, they can be physically isolated, but they need care. They need people coming in and out, putting on and taking off PPE and the sort of precautions required for people with an infection like COVID-19. It is an enormous increase in workload. And when you've got a limited number of staff, that inevitably means that the care of care of all residents is likely to be less than it would otherwise be with the same number of staff. And so I felt very strongly, looking at this from the outside, and I still feel very strongly that it's not just a matter of making an assessment about the medical needs of the resident, but also about the capacity of the available staff and the facility to care for both the ones who are positive and negative for the infection, whatever it is.
Yes. I take it from that answer that you've identified at least two dimensions of the issue. That is the consideration of what's clinically required for a particular resident, but also what might be described as a broader public health consideration of your ability to look after the residents as a group, all the residents that you're responsible for as a provider.
There is a third perspective, of course, and that's the desire of the resident and their relatives about their care. And it's true that, as I understand it, many aged care residents are very reluctant to go to hospital, at least when they're well. And particularly those who have any cognitive impairment or are living with dementia. I think a move to a very alien environment like a hospital must be very distressing. On the other hand, even if they're in a familiar environment, the fact that they have carers and staff who are often in the first phase of an outbreak unfamiliar to them, and their faces are covered and often muffled, it's an unfamiliar environment even in the home where they normally live. So
yes.
I think it's something that can be managed, and that their wishes in terms of end-of-life care can be respected in a hospital setting as well, without significant risk to them, if that is better for the overall well-being of the other residents in the home.
Thank you, that's very helpful, Professor. Are there countervailing considerations in terms of the impact on, say, a particularly frail resident or a resident suffering from dementia, where the consequences of any sort of transport, especially to hospital, could be very deleterious to their well-being?
I'm sure there are.
Yes.
But I mean, it's like many other things. I don't think you can make a blanket rule about these things.
Yes.
The whole point of good clinical care is treating each individual patient, and I'm sure the same applies to aged care, each individual resident, on the merits, on what they want, what is best for the community and the specifically the community in which they live. And it is a matter of judgment as to exactly what happens to any individual person in that setting. So yes, I'm sure that it's difficult in that to transfer someone to hospital or to another facility for that matter.
Yes.
But it may still be the lesser of a variety of difficult choices, or the best of a variety of difficult choices.
Yes, thank you. That's very helpful, Professor. Finally, can I just ask you about you've mentioned Newmarch House, and you're aware of the circumstances there. The evidence before this Royal Commission from Mr. Lai of the Commonwealth Department of Health is that you were part of the senior case management meetings in the Newmarch House response. Is that right?
That's correct, yes.
Yeah. And I won't ask you about your experience. We've got other evidence which we're going to hear tomorrow about Newmarch House. But just as you were asked by the Commonwealth Government to produce a report in relation to Dorothy Henderson Lodge, you've also been asked to produce one in relation to Newmarch, have you not?
Correct.
And it was due to be provided to the Commonwealth last Friday, the 7th of August, but no doubt because of many competing demands on your time, it's going to be a little bit later than that. Is that right?
Well, we provided a preliminary report last Friday. So the Commonwealth does have what will be pretty close to our final report, but we've undertaken to provide the final report, if you like, next Friday.
Thank you very much, Professor. They're all the questions I have for Professor Gilbert. Commissioner Briggs, do you have any questions? I think you might be on mute.
I'm on central mute.
No, we can hear you. We can hear you now.
You can hear me now? Okay, I said I had no questions. Thank you.
Oh, thank you. Commissioner Pagoni.
Professor Gilbert, thank you very much for your assistance throughout all of this. It's been very helpful indeed, and we've learned a great deal from your evidence today and the assistance that you've given up until today. So thank you very much indeed. And I think I should formally excuse you from further attendance.
Thank you.
Thank you, Commissioner. Mr. Bolster will take the last witness today.
Yes, Mr. Bolster.
Thank you, Commissioner. The next witness is to be identified by a pseudonym, and the pseudonym is U.Y. And I therefore call Ms. U.Y. Perhaps if the witness could be sworn.
Ms. UY, do you solemnly and sincerely declare and affirm that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say I do.
I do.
Ms. UY, you have prepared a statement dated the 5th of August this year,
Yes.
correct?
Yes.
And do you have a copy of that in front of you now?
Yes, I do.
Do you wish to make any amendments to that document?
No.
And to the best of your knowledge, are the contents of the document true and correct?
Yes, true.
Commissioner, I tender Ms. UY's statement, which is WIT 0971 0001 0001.
Yes, thank you. The statement of the witness identified for anonymity as witness UY is Exhibit 18-7.
Now, Ms. UY, you made a submission to the Royal Commission about the experiences of your late father in residential aged care during the current pandemic in Melbourne, correct?
Correct.
And your father was living in an aged care facility near where you live, correct?
That's right. That's right.
And he died in June of this year, is that correct?
Yes.
But he did not test positive at any stage for COVID-19, did he?
Not at all. Not at all.
Tell us about your father. How old was he when he died?
82. And yeah, he was 82. And yes, he had motor neuron disease. And,
He'd been a farmer?
well, yeah, back in Italy, almost everybody was a farmer who came from the south of Italy. But yes, he was a farmer, outdoor man.
He was an outdoor man. He was an active man, wasn't he?
Yeah, very active, digging, always in the garden.
And the diagnosis of motor neuron disease, when did that happen?
About 2016.
And What was the effects of that on him?
It was a gradual process. He began slurring and then eventually lost his ability to speak altogether. So his ability to have conversations became very minimal. And it started to affect him, I think, even from a point of view of his mindset, and his dementia started to kick in a little bit more. And yeah, it was sad, but he was happy because we could still communicate, you know, thumbs up and handshake, hugs, go for walks, and we made life as normal as possible.
Before he went into care, how often were you in contact with him and caring for him?
Always. And even while he was in care, I was with him. I was with him almost every day, like as much as I could, because I knew he needed that physical contact. He couldn't speak. He was always also giving a lot of people thumbs ups and handshakes all over the centre. It was his way of communicating. He was kind of happy like that. He was still going on and surviving and doing well.
He moved into aged care in May of last year.
Yeah, it sort of ended up being the beginning of June, because in May he went into hospital, and that's what, after the hospital, he went into the nursing home after that.
And I think in your statement you mentioned that he had a PEG tube.
Yeah, it got complicated. Yeah, it got complicated for my mum because his voice went, but his whole swallowing system started to be affected.
Right. So he was living with your mum, but close to you?
Well, no, they were living in 25 minutes away from me, and I was going to see them, but then I decided to put him closer to me because I would be his primary carer.
All right. Now, how was the facility able to look after him before COVID came along?
Very well. Everything was smooth, and it was like an extended home. You know, as far as looking after him, feeding him, making sure that, you know, all the medical stuff was taken care of, that was done very well. Even his room, everything, clothing, everything was fine until the whole COVID crisis hit.
And how did that play out in terms of lockdown for your father?
Yeah, well, it was a whole different picture. It wasn't what we'd signed up to, although we needed them. We needed them because he was being looked after, you know, feeding and making sure he was physically well. I'm just not sure about the emotional side of it. They did their best, but there was aspects that only I could do.
Let's talk about an incident that you relate in your statement in paragraph 9. And that's the 17th of March, when you say it was the last time you had a physical visit with your dad.
Yeah.
In the ordinary sense.
In the
You
ordinary
understand what
sense.
I mean by that?
Exactly. So I'd go into his room, come on, Dad, up out of your chair, let's go for a walk. And, you know, I'd sort of get him to walk with me, put on his cap, put on his jacket, and we'd go for a walk. An hour and a half, an hour, we'd go around the whole block, we'd go to the park. This time he wanted to go, I took him around the whole block. So it was a long walk.
Did you measure how long the two of you walked?
Probably an hour. And we stopped and walked, and it was just beautiful. And he'd stop and look at the trees and just wonder, and then he'd just keep going. But he was actually pulling me along that day. I'll never forget it.
Right. After that, describe the contact that you had with your father.
Windows. And it was sudden, and it was a big sudden change. And I think it was everybody had a sudden change, including those that were working in there with him. And it wasn't like they were happy about it. I'm not saying they were happy about it. They were just, you know, this is all we can do right now. And it was like common sense. This is all we can do. You know, this is what we're all doing. And you just went along with it, not realizing how long it was dragging on for and the impact of what that would mean.
So you couldn't ring him up and tell him you loved him?
Not really, because he couldn't speak back. So a phone call in his case wouldn't really work. And you know, technology wasn't my dad's thing. He doesn't get that. And even if we did the iPad and, you know, hands up, thumbs up, he'd do it. But it wasn't the same as, you know, grabbing him by the hand or the arm and walking him.
So the window access, how did that develop?
We made it fun. You know, we kept talking, hands. We did a lot of hands. He used to find my hands on the window and he would follow my hand. As I'd move my hand, he'd follow the hand. So he was matching my hand, standing up, sitting down, fingers, thumbs, all that kind of thing. We just tried to turn it into some sort of fun thing to do.
Was that outside his bedroom?
No, because he was upstairs, so we had to go downstairs. So I'd pick times when he was on his way down, just before dinner or just before lunch, because they'd have to go get him. Because he wasn't, unless you go and get him, he wasn't always just willing to walk around. He lacked a little bit of that motivation, I think.
Was the facility cooperative with
Yeah.
your attempts to communicate?
In the
with him?
beginning, they were. I think then I tried to come like every day. Like I thought, you know what, I've got to find half an hour to go see my dad. I got to go find it. And because it wasn't far from my home, I'd go there and I'd go to the window and they'd bring the chair down. They would bring the chair down. Sometimes my dad would even pick up the chair and put it away and we'd say, don't touch a chair. But they would have it ready. Like I'd go down, they'd bring the chair down. They were willing. It's just that it was complicated because there was only one window. There was only one door. So if I was taking up that whole time, I knew that perhaps others wouldn't be able to do it.
Well, were there other people queuing to see their loved
Sometimes
ones?
there was, I wasn't there when that happened, but there was one time that I couldn't see him because it was just too busy.
Right. Now, you say in your statement in paragraph 10 that when the nursing home went into lockdown, that it seemed to me that there was panic almost immediately. What do you mean by that? What was the panic that you observed?
That's my interpretation. I call it panic because I think intelligence wasn't really as good as it could have been. And I think what's happening there's not a lot of power I felt in this situation, an unknown, it's a situation that everybody's just been thrown into. It was like, I say panic because that's how it looked like to me, in the sense of not well thought out and not planned. So I call it panic because it's like reactive.
And how did they communicate the lockdown to you? Was it explained to you? Were questions that you had answered?
It took a long time before we actually had the visiting system set up. So I feel it was like a 3-week to 4-week period between the moment I came back from that quick holiday that I mentioned. I had to come back because we were on a bit of after the 17th, we had gone away. We had to be back in Melbourne because we went into lockdown. That was about, like, for me, 4-week gap before we could actually book in your half an hour visit. So I was just at the window for a long time. And they're just doing their best. They were doing their best, but there was a lot of gaps, I believe.
What did you see in your father's condition change over time?
Confusion, just a massive confusion. I mean,
how did that demonstrate?
Well,
how did that demonstrate itself?
Just looking at me like in a way that he was confused. He was trying to press the buttons to try to get out of the room. He was trying to open the door, and we would go, "Sorry, Dad, there's an there's a virus." In Italian, I would say it. You know, we would just try to make him understand that it's funny. My mum was even, referring to the Bible, end days. It was the end days. The end days have come, there was stuff like this going on. And just to try to help him understand that we're in the end days, and I think, it doesn't matter what he believed, but he kind of accepted it. He would then accept it and he would sit down. But it was just sad.
What about your mother? How did this affect her?
Well, she didn't come and visit him for about a month. So I was the only one going to the window because at that point I was going to get my mum, and not until we could actually enter in for visiting that she was then coming in. So for a long time between the lockdown and the implementation of the visit, I was the only one going to the window, and my husband would come, but we didn't get my mum to come down. She wasn't going to stand at the window and talk to him at the window. I felt that would be too difficult for him emotionally.
When did a system of visitation get established?
I believe it was about 3 to 4 weeks after that. From the whatever the lockdown would have started, I believe it may have been 26th of March, whenever Victoria hit lockdown, because I'd just come back from my short holiday. And so that first visit, which I got wrong, I ended up booking in another venue. I've said that in the statement, and I had to wait another week. So I just continued doing. I was grateful for the window visits. I mean, I felt like I'm a beggar now, and like I'm glad to see my dad. At least I get to see my dad at the window, and that's how it felt.
And what was the process for seeing your father?
At the window?
No, I'm talking about the visits when you were in
Eventually.
the old hairdressing salon.
Well, that was the thing. Okay, so they converted the hairdressing salon into a visiting room, which was quite small, and so that first visit was terrible, and I wrote an email about it. It was smelt of domestos. There was a perspex in between. My dad couldn't shake our hands. We were wearing masks. He could shake the nurse's hand, but he couldn't shake our hand. He walked out very confused, and I remember his eyes. I can still see it now. And as he walked out, he was like, "What's this? A visit? Is this a visit?" So it was not a visit, and I was really, really upset that day. So that's when I ended up speaking to Banksia Care and then OPAN.
And so the result of that was you were able to have some visits with him in the garden, correct?
So then I spoke to OPAN, and they arranged a conversation with management, and we then said, "I'm not ever going in that room again. I'll stay at the window, thanks." But I wasn't angry. I was just, I felt helpless. Like I didn't know what to do. And I knew my dad, to leave him like that was terrible at that moment. Don't know how he coped with that. I still don't know how he coped with that.
Okay, so 14th of May, you're able to have a visit in the garden with your father.
That was lovely.
First time you've been able to get close to him since March. How was he coping at that stage?
Yeah, so at that point, I bring my mum for the first time. Okay, so from March, probably 17th also, until 14th of May, my mum hadn't been there because there was no system for her. Oh, other than that room that we'd been in. Okay, so we go to the garden. It was lovely. At that point, I was holding his hand. But, we weren't allowed to do any of that. You couldn't really hold his hand. I couldn't hug him. He walked out the door, he'd go to hug me, and I'm like holding back. And it was unexplainable. Like, how do you explain that?
And then how many times did you see him in the garden?
Probably 4 to 5 times until he, so the last visit in the garden would have been, because he went to sleep on that Saturday night. I think it's the 6th. So work 3 days back from that would have been the Wednesday was the last time we'd saw my dad, the 3rd of June, roughly, in the garden. He was out of it by then. He was out of it. By then he was, he did give my mum a very, very big hug. As he walked out the door, I didn't hug him because everybody was there, the nurses were there, and we weren't really supposed to. I said to my mum, wait. Then we went to the back where nobody could see us, and we were sitting in the garden, and he just hugged my mum very, very tightly, and my mum could not feel. I actually videoed it, and it was such a tight hug. He understood, but he was just cognitively, he was losing it. He was just vague. And we showed him a beautiful song that we played at the funeral called Andrea Bocelli's, Fall on Me. And we were showing him, because he looked a little bit like Andrea Bocelli's with his glasses and his cap. And we were showing him this song, and then we did play it at his funeral.
So just describe for us the change in your father from the 5-kilometre walk in March to this last visit in the garden in May, just over 2 months.
He was just vague, but he was also picking some stuff on my mum's face. He was leaning over, but he was just not there. Like I think he'd already, I reckon he'd given up. I definitely losing it a lot. I think he lost about 30%. It was already pretty bad as it was, but because, the walk, but I couldn't walk with him like that.
Had he lost weight in that period?
No, it wasn't lost weight. No, it was more cognitively. He wasn't. I couldn't go for a walk like that with him, and neither could we get out of the premises anyway. But he wasn't capable of doing what he had done. No, he lost a lot. Yeah.
I was wondering if you could please read to us paragraph 26 of your statement, just so that we can
Okay.
hear the way you've expressed yourself there.
Okay. I believe that I could have taken Dad by the hand and walked him around. Even if I was wearing a glove, we could have still had a relationship. I felt as though I was no longer trusted to care for him, even though I had been only weeks and months before. I lost this connection with my father, and I felt as though he'd become the nursing home's property. I felt like my family were no longer considered to be important, and instead the nursing staff and management were the best people to look after Dad. This feeling was really enforced, like my family were outsiders and my dad was the insider. I believe that during this time, love was not the biggest priority, but enforcing the system was. I felt that all that had been promised when Dad entered the nursing home had changed. All the wonderful leisure and freedom aspects, such as coming on visits to my home and being able to take Dad shopping and for walks, had all gone suddenly overnight because of the virus.
Thank you for that. Now, in paragraph 28, you talk about the importance of his blood support from a cultural perspective.
Yeah.
Could you elaborate on that? Explain to us what you mean there.
Yeah, I mean, he loved the people at the nursing home and he was so thankful, and so are we. We're absolutely thankful for the wonderful help they gave him, and they did their best. But nothing matches family, and family is the rooting systems, particularly for Italian people. You know, we promised him that we would be there for him. And suddenly, because of a huge system change, because of, you know, a crisis, we had to get back to bare minimal, which is structured, focused, rather than, you know, family focused. And I think nursing homes are all about families and people. And it had to, in its urgency, had to resolve itself to having systems and processes, because there was deep fear of the place becoming contaminated. And I don't know to this day if it's happened there or not, but there was a real fear. We don't want to become like some of those other nursing homes around, and we've got to protect everybody. And I kind of get it. It's not like I don't get it. But how do we intelligently do this and maintain family in a situation like that? And I have made some recommendations.
Yeah, we'll come to that in a minute. If you could please explain how your father passed away. I mean, he was asleep, as you say in the statement, for nearly a week. And you saw him in a wheelchair, which was the first time he'd been in a wheelchair.
First time ever. He used to hate wheelchairs. So even if I put him in a wheelchair to take him to the shopping centre so we can go quickly, he would not take the wheelchair. He would refuse it. So I had to put it back, right? But that last day, so, you know, we'd done the garden visit, maybe the Wednesday, I think it was. And then by the Saturday or Friday night, I was at the window. Sorry, Saturday night, I was at the window doing one finger only. He could barely. He was wheeled out in a wheelchair. He was very lethargic, run down. I believe he was switching off. It had nothing to do with his food. He may have had an infection, I'm not sure. But at the end of the day, he couldn't really respond to me. So he was just doing one finger at a time, if that, and then he would just wander off. And I knew he didn't look right. He looked very unwell. But, you know, those things, I couldn't tell the nurses what to do there, really, because, you know, they're the medical staff. So I could only see it from my emotional point of view, but our hands were tied. There wasn't much we could do, really.
And the facility gave the family an opportunity to be with him because it was clear what was going to happen?
No. So what happened from that point is they took him to dinner from that window and said, let's see if we'll have some dinner. And then I don't know if he did have dinner, but he was taken to his room and he went to sleep. And that was it. We didn't see him anymore after that window visit. He went to sleep and he just slept, and he peacefully passed away, which is the most beautiful way of passing away, and gave us enough time to come in and visit him. But he didn't wake up again from that Saturday night that I know of. And he was tested for COVID that night, or either Sunday, he was tested for COVID on the Sunday.
But when he was asleep, the facility let you come into the room?
Yes, after he was, so that Saturday night he went to bed. Sunday they did the COVID test and they made sure, because he did have a temperature, so he was okay. We got the information Monday. And then by Monday we were in there visiting, hoping he'd wake up, of course, but he never did.
Now, you include a number of reflections and recommendations in your statement, which are set out there at some length. Was there anything in particular that you wanted to communicate to the commissioners in addition to what's there?
Just overall, the nursing home did everything well. You know, looking after my dad prior to the COVID virus, the environment was good. It wasn't perfect, but it was good enough and it was great. We were happy with it, and I had flexibility to go and take my dad and be with my dad and fill the gaps. So what I was doing is filling the gaps, playing the games, taking him for walks, and all the stuff that I could do that he wasn't getting and needing, and he needed it from a family member, right? But when the virus kicked in, I say it was a panic, because there was this tremendous shift with not necessarily a focus on what was already existing and how to maintain that. What we needed to do there is to maintain at least the key visitors for each person. And so I would have liked to maybe have been treated a bit differently, in the sense of, you know, we know you've been here all the time. Can we allocate one family member to continue visiting their loved ones if they want? Not everybody gets the visitors like what I was giving my dad.
Two more questions. One is about the fact that your father was on a level 4 home package before he went into care.
Yes.
And one of the reasons why he went into care was problems with the delivery of that package.
100%. Yeah.
What were they? What was the thing that made the difference?
Different people walking in all the time. Even though you have, you know, a particular care company, their staff aren't always reliable. They're not in, they're sick. So you bring in another person. So every time a new person walks in, you start again. One, getting to know them. That wasn't me. It was my mum having to get to know them, trust them, start again and explain how she wants things done. So she was having to repeat herself all the time. And the more she repeated herself, she was getting exhausted, you know. And so too many people walking in and out, too many different people. I think that's the main thing. We didn't have 2 people rotating. It was different people coming in all the time, and then cancelling at the last minute too, that kind of thing. So it wasn't reliable.
My last question, I'd like you to please, if you could, read paragraph 38, the second last paragraph in your statement.
Yeah. Okay. A nursing home can never be what a family is to someone. It will never fill the gap. But it is a tool to help families and their loved ones. It will never replace the love and connection a family can give to loved ones. And it should not assume that it has the right and authority to do that. Even though most of the carers are beautiful people, genuinely doing their best, the nursing home didn't give my dad more days. It gave him less days. After what happened to Dad, I wouldn't put my mum in there now with the restrictions.
Thank you very much. I have no further questions, Commissioners.
Yes, thank you, Mr. Paulson. Commissioner Briggs?
No, I have no questions, thank you.
Yes, thank you. I'm sorry to be referring to you by the pseudonym, but that's unfortunately what it has to be. Thank you for giving us as evidence. It has been important to hear what people like you have had to say and the experience that you've had. It's important for the entire nation to hear of these kinds of events, and it will help inform us in the conclusions that we reach. So
thank you very much.
Thank you very much for coming out.
Thank you very much.
Thank you.
That concludes today's evidence. Commissioner, it's a 9:30 start tomorrow.
Yes, I think I should formally have excused the last witness. I always seem to forget to do that, so I do formally excuse her from further attendance, and we'll adjourn until 9:30 tomorrow morning.
The Royal Commission is adjourned until 9:30 a.m. on Tuesday, 11 August.